principles regarding this. First, I welcome Dr. T.P. Jayaraman, State President. A warm welcome to you, sir. Dr. Anil Matthew, Chairperson, Nephrology Chapter. A warm welcome, sir. Dr. Radhika C.R., Secretary, Nephrology Chapter. Warm welcome, Madam. Dr. M. Vijay Kumar, President-elect. Warm welcome, sir. Dr. Johnny Sebastian, State Secretary. Warm welcome, sir. And Dr. M. Narayan, Immediate Past President. And Dr. Sajid, Secretary, IAP, Cochin Branch. Thank you.
Next, I welcome Dr. Anil Matthew, President, Nephrology Chapter, for his presidential address. Anil, sir.
Dr. Anil logged out and he's logging in again.
Dr. Anil Matthew is waiting in the waiting room. Please admit him.
Yeah, but he's yet to log in. He's not seen.
He's already joined. He has joined.
Okay.
Anil sir, please unmute and stop.
He was not.
Dr. Anil is muted.
Dr. Anil was unable to unmute. He is joining back again.
Yeah, I think we'll go to the secretary's report next item if there is some technical issues with any. Again, you can join and join us later.
Okay, sir. I think it's just joined back.
Yes, joined.
And sir, you can unmute yourself and talk.
Still muted.
Shall I go to the secretary's report then?
Yeah, that's please.
Respected Jayaraman sir, Kerala IAP President, Dr. Vijay Kumar, IAP President-elect, Dr. Anil Matthew, President, IAP Nephrology Chapter, Dr. Pramod Warrior, President, IAP Cochin, and other luminaries of IAP, senior colleagues, and dear friends. It is my honor and duty to present to you the Secretary's report of Nephrology Chapter of IAP Kerala for the past year. 2020-21 was a busy year for nephrology chapter in spite of being a COVID year. Even though we started slow, there was a flurry of high quality activities. On November 8th, we had the 13th inaugural state conference, Nephro Kit. It was hosted by IAP Malanad, and though it was initially planned as a real event, it had to be conducted on a virtual platform due to COVID situation. But it was well attended by 255 delegates. We had 6 talks from various experts ranging from urine analysis to hydronephrosis to glomerular nephritis to voiding dysfunction, acute kidney injury, and complicated nephrotic syndrome. We celebrated the World
Sir, I
Kidney
am now unmuted, sir. Had some technical issues. Yes.
We celebrated World Kidney Day on 12th March 2021. The theme was Living Well with Kidney Disease. And keeping with the theme, the nephrology chapter, along with IAP Thiruvananthapuram, released a short video compilation of dance, art, and music by children suffering from chronic kidney diseases. Many children on dialysis, kidney transplant, and other kidney diseases from SAT Hospital and AIMS Kochi performed in the video, which was nicely compiled by Dr. Praveen KS. We also conducted an evening CME as part of the World Kidney Day celebrations. The World Kidney Day message was delivered by Dr. Satish Balan, President, Trivandrum Nephrology Club. There was also a talk on the topic Nutrition and Diet in Kidney Diseases, which was given by Dr. Elizabeth Madam. There was also a panel discussion on queries in nephrology from practicing pediatricians. It was moderated by Dr. Bennett Sailam and Dr. Bindusha, with Dr. Susan Udap, Dr. Anil Matthew, Dr. Manju Thambi, Dr. Liji, and myself as panelists. Department of Pediatric Nephrology, SAT Hospital, has an International Society of Nephrology Sister Renal Center collaboration with Cincinnati Children's Hospital, Ohio, USA. Making use of this collaboration, the nephrology chapter, along with IAP Thiruvananthapuram and Trivandrum Nephrology Club, are conducting a masterclass series in pediatric nephrology to meet a felt need among pediatricians and practicing nephrologists to tackle the common pediatric nephrology issues. This helps us to make the knowledge in pediatric nephrology accessible to everyone at their homes. We have around 125 registrants for this NephQuest Masterclass series, and which was started on 3rd July 2021 and is still ongoing. The sessions are on Saturdays every week and rarely on Fridays, in the evenings, and is expected to end by January 2022. I would like to place on record the support from Pediatric Nephrology Department, SAT Hospital, IAP State Branch, Thiruvananthapuram Branch, and Trivandrum Nephrology Club for the conduct of all activities of nephrology chapter last year. I would like to thank the IAP Kochi for support in organizing Nephro Kit 2021. Hope we can meet in person next year. Thank you. Jai Hind, Jai IAP. Now I welcome Dr. Anil Matthew sir to give his address.
Respected Dr. T.P. Jayaraman, sir, President IAP Kerala, Dr. Pramod Warrior, President IAP Cochin, Dr. Sajit Son, Secretary IAP Cochin, Dr. M. Narayanan, sir, and other seniors of IAP, Susan Udap ma'am, Dr. Radhika, Secretary, Nephrology Chapter, all members of IAP, especially IAP Cochin and Nephrology Chapter, a very good morning to one and all. Sorry for the initial technical snag and delay. Medical sciences is an ever-changing field, and pediatric nephrology is no exception. Rapid advances have taken place in the diagnosis and management of various renal problems in children. Pediatricians and other first contact physicians bear a heavy responsibility of making a prompt diagnosis and carrying out the initial therapy. A large proportion of renal disorders are chronic or recurrent. They require long-term care and surveillance. Psycho-emotional and socioeconomic factors are very important in such cases and need to be tackled appropriately. Such patients need to be jointly cared for by the pediatrician and the pediatric nephrologist. In a developing country like ours, the effort must be directed towards appropriate therapy, cost effectiveness, and preventive nephrology. In Kerala, pediatric nephrology as a branch of pediatrics is still in an evolving stage, even though the adult nephrology has grown leaps and bounds as a specialty. Thanks to the passion and dedicated efforts of our mentor, Dr. Susan, we have come a long way over the past 15 years or so. From a stage nobody knew what pediatric nephrology was, to a stage where we have a handful of pediatric nephrologists in the state. Nevertheless, the infrastructure of pediatric nephrology is still not widely available. There is still lack of awareness among the general public about the availability of specialists trained to manage kidney problems in children. The major challenge that we face today is making quality pediatric services, more pediatric nephrology services, more accessible and affordable. Pediatric nephrology department as SAT Thiruvananthapuram has set a role model in this regard. Today, IAP Cochin and Nephrology chapter IAP Kerala together have arranged a common platform for pediatricians and pediatric nephrologists to address a few challenges in the arena of pediatric nephrology practice. I hope NephroKit 2021 will provide a perfect platform for participants to interact with the speakers to gain valuable insights regarding renal problems in children. As chairperson of Nephrology chapter, I thank all the speakers and participants for spending their precious time on a Sunday. I am also grateful to IAP Cochin, who is hosting NephroKit 2021, and IAP Kerala Secretariat for providing all necessary guidance and the Zoom platform. Let me conclude by remembering a quote by the father of our nation, Mahatma Gandhi. Live as if you were to die tomorrow. Learn as if you were to live forever. Wishing everyone a few hours of happy learning. Jai Hind, Jai IAP.
Next, I welcome Dr. T.P. Jayaraman sir, President IAP Kerala, to inaugurate NephroKit 2021 and to deliver his inaugural address.
Respected President of IAP Kerala Nephrology Chapter, Dr. Anil Matthew, Secretary Dr. Radhika, President of IAP Cochin, Dr. Pramod Warrier, Dr. Susan Uthup, the Founder President of IAP Pediatric Nephrology Chapter of Kerala, Dr. Narayananiyam, Dr. Vijay Kumar, Dr. Johnny Sebastian, Dr. Ravi, President NNF Kerala, Dr. Jozo, and all the other senior faculties and members on this platform. It is with immense pleasure I am attending this inaugural function of IAP Pediatric Nephrology Chapter. And as Dr. Anil was putting it, subspecialty chapters are yet to develop in Kerala, except especially pediatric nephrology, and we have to go leaps and bounds. And in this era of increasing pediatric renal ailments, and it is so important to have a shared care approach in these very common chronic pediatric conditions. And it is essential to have enough training programs and enough orientation of general pediatricians with respect to pediatric nephrology problems in the community, and again with respect to preventive nephrology in pediatric practice. And I congratulate the President Anil Matthew and Dr. Radhika and of course Dr. Susan for arranging excellent programs in pediatric nephrology in this regard. And my memories goes back to 2008 when we started the pediatric nephrology chapter, and I happened to be the founder secretary along with Dr. Susan as the president of this chapter. And in this time of when we are going for the Golden Jubilee celebrations of Indian Academy of Pediatrics, I consider this as an important event. Yes, and I thank Dr. Joseph Mulail, the then president, and Dr. Ananda Keshavan, and also one person who encouraged me to start the specialty chapter was our Dr. Jayakumar, who was behind me to take the initiative to start this chapter. I think Dr. Jayakumar must be here, being the National Executive Board and HOD of Amrita. If you don't know who was, actually Dr. Jayakumar was the person who instilled the confidence to start this chapter and the necessity to start this chapter as a specialty chapter of pediatric Indian Academy of Pediatrics Kerala. So with these few words, I declare this chapter, this conference open, and I congratulate the organizers IAP Cochin and IAP Pediatric Nephrology Kerala chapter for this wonderful event. Thank you so much.
Thank you, sir. Now I invite Dr. M. Vijayakumar, IAP Kerala President-elect 2022 to deliver his felicitation. Vijayakumar, sir.
Vijay Masar is not joined.
Narayan, sir.
Good morning to you all. Dr. T.P. Jayaraman, President of IAP Kerala, Dr. Vijayakumar, President-elect, Dr. A.V., President NNF Kerala, other senior leaders in IAP Kerala and IAP Cochin and the Nephrology chapter. Today we have assembled for the 14th annual conference of Nephrology chapter of IAP Kerala. 14 is an important milestone because it takes 14 years for the planet Jupiter to complete one revolution in its orbit around the sun. And of course, from the report read by Dr. Adhika, it is evident that during the last 14 years, Nephrology chapter has grown to meet the requirements in continuing medical education and training for all the pediatricians, practicing pediatricians and pediatric nephrologists of Kerala. And this conference has been meticulously planned by Dr. Anil Matthew and Dr. Adhika, of course, under the able guidance of Dr. Susan Udup. And I wish this conference all success and wish you all a happy learning experience. Thank you.
Thank you, sir. Next, I invite Dr. Susan Udup, our leading light, the guidance behind all the efforts of Pediatric Nephrology chapter, to give us a few words of wisdom and encouragement. Madam.
Thank you, Dr. Adhika, and thanks IAP for this great opportunity. Respected President, IAP Kerala, Dr. Jayaraman, past President, Dr. Narayan, Dr. Vijayakumar, Dr. Adhika, Dr. Anil Matthew, and all the colleagues and friends. And it is my privilege to be wishing this conference a grand success today morning. And memories are very fresh. And 2008 is the time when Dr. Jayaraman was hosting the first program of pediatric nephrology, when pediatric nephrology chapter was born. And now this chapter has grown to be an adolescent, and all the programs, whatever is happening with the support of all the IAP members. And also I have to place on record the support from Leni Kumar, Dr. Anil, Dr. Radhika, Dr. Janaki, and all the IAP members who are interested in pediatric nephrology for making this chapter do well. And I hope all future years we will be seeing more colors, and I wish this conference success. Thank you.
Thank you, madam. Now I invite Dr. Sajid Jones, Secretary, IAP Kochi, to give the vote of thanks.
Good morning, all. First of all, I want to my sincere thanks to the IAP Kerala Nephrology chapter to give us the opportunity to host this program. My special thanks to T.P. Jayaraman sir, our IAP Kerala president, Dr. Johnny Sebastian, our secretary, Dr. Anil Matthew, sir, Dr. Radhika Radhakrishnan, and my sincere thanks to Dr. Narayan, sir, Dr. Devi, sir, and Dr. Susan, madam. And my thanks to Dr. Pramod Warrior, the president, IAP Cochin. Thank you. Thank you all.
That concludes the inaugural session. Thank you everyone for participating. Next, we go to the scientific session. Thank you. So the first talk of the day is on a problem that every pediatrician who practices will face in their lives very often. It is really not a problem, but becomes a problem sometimes. And the guidelines keep changing once in a while. So the first talk is the most pertinent one. It's on steroid-sensitive nephrotic syndrome, new guidelines. So what has changed? What is new? Let us learn from Dr. Christy Catherine Thomas, who is an assistant professor in pediatrics, Government TD Medical College, Alappuzha. She has done her MBBS from GMC Kottayam, MD from Government Medical College, Tirunelveli, and DM from AIIMS, New Delhi. She has 3 national and international publications. Let's go to Dr. Christy and listen to her on steroid-sensitive nephrotic syndrome, the new guidelines. Over to you, Christy.
Thank you, ma'am. Am I audible?
Yes, you are. Please go ahead.
So, good morning all. Good morning, respected seniors, colleagues and students. Today, my topic is steroid-sensitive nephrotic syndrome in light of the new guidelines that has come the last 1 year. And as you all know, steroid-sensitive nephrotic syndrome is often managed by all the pediatricians. The pediatric nephrologist or the nephrologist will come into the picture only if there is difficult to treat nephrotic syndrome, or if there is any additional steroid sparing agents are needed. So we will see what is new and what is there in the new guidelines. The outline of the presentation will be, I will go through the introduction. After that, what we will see what has changed and what has no change in the new guidelines regarding the management of initial episode, relapsing nephrotic syndrome, and in the supportive care. So what we have followed till now is the national guideline. The nephrology chapter of the IAP has come forward with the national guidelines in 2001, and it was revised in 2008. The current guidelines are that of Indian Society of Pediatric Nephrology revised guidelines of 2021. What we follow the international guidelines are the KDIGO guidelines, which are there in the Nelson's textbook of pediatrics, the 2012 guideline, which is also revised in 2020. Both the guidelines are evidence-based and they give the strength of recommendation and quality of evidence, and they give it as recommend, suggest, or give us practice points. Coming to nephrotic syndrome, as we all know, it consists of heavy proteinuria, hypoalbuminemia, edema, or hypercholesterolemia. The common pediatric etiologies are classified into primary nephrotic syndrome or the secondary nephrotic syndrome. Primary nephrotic syndrome include the idiopathic nephrotic syndrome or the monogenic form. The secondary include the systemic causes like SLE, HSP, malignancy, amyloidosis, infection, or rarely due to drugs. So when we have a child with suspected nephrotic syndrome or an initial episodes of nephrotic syndrome, is there any change in the recent guidelines regarding the definition? What are the investigations to be done? When to do a biopsy, when to do genetics, what drugs or dose, duration of therapy has to be considered in the initial episode, that we will see in the next few slides. Regarding the definition of nephrotic syndrome, in the ISBN 2021 guidelines give the definition of nephrotic syndrome as nephrotic range of proteinuria, hypoalbuminemia, and edema. Even though hypercholesterolemia is often present in the nephrotic syndrome, it is not included in the ISBN 2021 definition, and the hypoalbuminemia cutoff has come down to 3 grams per deciliter. This is shared in the KDIGO 2020 guidelines, nephrotic range of proteinuria with hypoalbuminemia or edema. There is no change in the nephrotic range proteinuria definition. It is defined as early morning urine proteinuria demonstrated either by dipstick or boiling test, 3+ or 4+, or the heavy proteinuria, or the sport protein creatinine ratio more than 2 mg/mg, or time urine collection should show a protein excretion of more than 40 mg/m² plus per hour. Regarding the initial investigation that should be done, it's again the urine analysis demonstrate the proteinuria, and if or not there is hematuria, then you have to monitor the blood levels of urea, creatinine, albumin, total cholesterol. And since we have high prevalence of tuberculosis, we have to do investigation to rule out latent tuberculosis infection. The ISBN 2021 guidelines suggest additional investigations in case of lower respiratory tract infection when we are suspecting renal vein thrombosis, systemic infection or hypovolemia suspected, or in case of long diuretic use of polyuria, or when secondary causes of nephrotic syndrome suspected, or in case of liver disease. The investigations are enlisted here. Sorry, okay. So when to do biopsy? This will be the next question. We should do biopsy when there is persistent microscopic hematuria at the onset of there is associated gross hematuria, or when there is acute kidney injury which is not attributable to hypovolemia, when we have features of systemic features of secondary nephrotic syndrome, or in cases of steroid-resistant nephrotic syndrome, and if the CNI therapy is prolonged more than 30 to 36 months, or if the patient shows reduced renal function while on a CNI. The ISBN 2021 also suggests biopsy before initiation of steroid-sensitive nephrotic syndrome. What has changed? The previous Indian guidelines states that the biopsy should be done in all cases of infantile nephrotic syndrome. The current guidelines suggest genetics. Before initiation of CNI, the previous guideline recommended biopsy. Currently, it suggests biopsy only if the patient is having an unclear or prolonged course. When to do genetics, the recommendation for genetics are limited in case of initial episode of nephrotic syndrome. That's done in case of congenital nephrotic syndrome, resistant infantile nephrotic syndrome, if the patient is already having a steroid SRNS, familial SRNS. The test recommended is clinical exome sequencing. Regarding to the first episode of nephrotic syndrome, the current guidelines, there is not much change in the dose and duration of the steroid therapy compared to the previous guideline. The agent preferred is prednisolone. It can be given either dose weighted or the body surface area weight based, or the body surface area based. The dose is 60 mg/m² or 2 mg/kg. Maximum of 60 mg for 6 weeks, and the alternate day therapy is 40 mg/m² or 1.5 mg/kg, maximum 40 kg for 6 weeks. The total duration of therapy is 12 weeks. So what has changed? In the ISBN 2021, it prefers younger children to be dosed based on the body surface area. Coming to the KDIGO guideline 2020, the 2012 recommendation was to give steroid daily for 4 to 6 weeks, followed by alternate day for 2 to 5 months, which is given in our Nelson textbook of pediatrics. But the current, considering the recent evidences, the KDIGO has came down to the steroid therapy to 8 to 12 weeks, 4 plus 4 weeks of daily plus 4 weeks alternate therapy, or 6 plus 6 weeks as in the ISBN guideline. This is a recommendation, and they have given a practice point. It's like in a younger child with 1 to 4 year old child with delayed response to prednisolone, that is remission 10 to 15 days from the treatment initiation, we can consider prolonging the treatment of initial episodes to 6 to 24 weeks to prevent further relapses with similar side effect profile. Another important point that is mentioned in the ISPN 2021 is the urine protein monitoring or keeping a diary. ISPN recommend that the patient should be told to maintain a record of proteinuria, infection, medication. And this is a prototype. It's like you can record the date, urine protein, prednisolone dose, other drugs if the patient is having problem or remark. This will help in the early recognition of relapse and may help in prevention of complication. This ensures the active participation of the patient and the parent too. So, in a case of steroid-sensitive nephrotic syndrome, after an initial episode, the important predictive marker is the steroid response, which is seen in 80 to 90% of cases, and the 10 to 20% may turn out to be steroid resistant. Out of this, 50% children may become frequent relapsing nephrotic syndrome or steroid-dependent nephrotic syndrome. 30% may become IAP, and 20 to 25 may have no further relapses. Out of the steroid sensitive, 3 to 6% may later turn out to be steroid resistant. The pediatric complications at the pediatric age group, the complication that we are expecting include AKI, which is relatively rare. Other complications include short stature, obesity, hypertension, mineral-borne disease, ocular complications, and diabetes mellitus. Usually the children will outgrow nephrotic syndrome, but adult relapses are noted in 5 to 42% in various cohorts. Obesity and reduced bone mineral density is an association which is seen in adults with childhood onset of nephrotic syndrome. So we have seen the initial therapy of nephrotic syndrome. Now we will see what the guidelines has to say about the relapse in nephrotic syndrome. What is the therapy? What is the is there any change in FRSD definition? How to follow up? They are giving guideline when and how to select continuation of steroid or steroid sparing agent, dose, duration, and follow-up of children on these steroid sparing agents. Coming to this therapy of relapses, actually there is no much change in the management or drug dose or duration. It's again 60 milligram per meter square or 2 milligram per kg until remission. Then we come down to alternated doses for a duration of 4 weeks. Coming to the definition of frequent relapse nephrotic syndrome and steroid-dependent nephrotic syndrome, according to ISPN 2021, frequent relapsing nephrotic syndrome is defined as more than 2 relapses in first 6 months after stopping initial therapy, more than or equal to 3 relapses in any 6 months, or more than or equal to 4 relapses in 1 year. STS-NSS definition is similar, more than 2 consecutive relapses while on alternate day prednisolone or within 14 days of discontinuation. What is new? It's like 3 or more relapses in any 6 months is included in the ISPN 2021. And if a patient relapses on full dose steroid, it should be considered as SDNS according to the KDIGO 2020 guidelines. It's the new addition. While following up the patient, while patient having relapse, we should document the blood creatinine, albumin, and electrolytes, and additional investigation as suggested. Or if the patient is in follow-up and not in relapse, you have to check the urine protein diary, anthropometry, features of steroid toxicity, and is there any evidence of evolution of steroid resistance. Coming to the steroid sparing agent, the indication is when the patient is having frequent relapse in nephrotic syndrome, STNS, or steroid toxicity. The selection of the steroid sparing agent should be individualized. It should be based on the age of the child, steroid threshold of the child, steroid presence of steroid toxicity, whether it is significant or not, or if there is any, what is the severity of relapses. Additionally, the drug efficacy, adverse effect, cost, and availability should also be considered in selecting the agent. All steroid sparing agents are started at remission, and they are usually co-administered with steroid for a duration of 2 weeks to 3 months. We have to monitor side effect, maintain urine protein diary, again, document relapse, and in cases of steroid sensitive nephrotic syndrome. So what is the algorithm that should be followed according to the ISPN 2021 guideline? In case of frequent relapsing or steroid-dependent nephrotic syndrome, we usually prefer the alternate day low-dose steroid as the initial management, preferred management. Following that, if the patient is developing frequent relapses, or the patient is failing the alternate day therapy, or the patient is developing steroid toxicity, we have to look for three things. One is more than one complicated relapse. The complicated relapses are defined as relapses with hypovolemia requiring inpatient care, severe infection, or thrombosis. Whether the patient is having a steroid threshold of more than 1 milligram per kg, or the patient is having a significant amount of steroid toxicity. Significant steroid toxicity is defined as hyperglycemia, obesity, short stature with low height velocity, ocular side effects, myopathy, osteonecrosis, and psychosis. The patient is having these features, then we have to prefer a more potent drug. Otherwise, we will prefer levamisole or MMF. If the patient fails levamisole, then we can consider mycophenolate mofetil, and in an older child, we can prefer cyclophosphamide. If the child turns out to be, child fails levamisole MMF, or if the patient becomes difficult to treat nephrotic syndrome, defined as frequent relapsing nephrotic syndrome, or patient having IFR with significant steroid toxicity with failure of 2 or more steroid sparing agents, including levamisole, cyclophosphamide, and MMF, then we can label the patient as difficult to treat nephrotic syndrome. The agent preferred is cyclosporin or tacrolimus or the calcineurin inhibitors. In the current guidelines, only after that the rituximab is preferred, but there are some special situations. Coming to each method, the first one is a long-term alternate day therapy. The dose of the steroid recommended is from 0.5 to 0.7 milligram per kg on alternate days, and we can come down to 0.2 to 0.3 milligram per kg per day if the patient is tolerating. The duration is 6 to 12 months, and it can prolong depending upon the physician discretion. The response expected is around 43 to 82.5%. Patient should be screened for steroid side effects, hypertension frequently. Then comes levamisole. Levamisole is preferred in cases of frequent relapse in nephrotic syndrome than in steroid-dependent nephrotic syndrome. It has similar efficacy compared to MMF and cyclophosphamide in frequent relapse in nephrotic syndrome, but less efficacious in steroid-dependent nephrotic syndrome. The dose is 2 to 2.5 milligram per kg on alternate day for 2 to 3 years. It can be prolonged up to 2 to 3 years. The side effect profile include leukopenia, rash, ANCA-positive vasculitis, high transaminase, and seizures. So we have to monitor for this. Then mycophenolate mofetil or the MMF. It has, in case of frequent relapsing nephrotic syndrome, it has similar efficacy to that of levamisole, but lesser than that of calcineurin inhibitor. But it performs better in steroid-dependent nephrotic syndrome. The main attractions include it's more efficacious in young children, and there is lack of nephrotoxicity. The dose preferred is 600 to 1200 milligram per meter square per day, and it is better to document the drug level by AOC. The drug can be continued up to 2 to 3 years. The side effect profile include abdominal pain, diarrhea, nausea, weight loss, viral warts, leukopenia, elevated transaminases, and infection. We should note that the drug is teratogenic. So we have to monitor for the blood counts and transaminases 3 to 6 monthly for the side effect profile. Then comes the cyclophosphamide. Because of the risk of gonadal toxicity and malignancies, it's often preferred as the second line after MMF levamisole failure. It's more efficacious in older children. It's like more than 7-year-old. It can be preferred as an older child with significant steroid toxicity, as I already told, or in cases of complicated relapses. In adult onset of minimal change disease, it's a first-line agent. So we should remember that we, especially in young children, we prefer it as a second-line agent only. The dose is around 2 to 2.5 milligram per kg for 8 to 12 weeks. It's a single course and it should not be repeated. The side effects include leukopenia, alopecia, infection, hemorrhagic cystitis, risk of gonadal toxicity, and malignancies. We have to maintain hydration, discontinue in case of significant infection, and we have to monitor total leukocyte count. It should be co-administered with a prednisolone dose of 1 mg per kg per alternate day. And it should be discontinued. The steroid should be discontinued after 4 to 8 weeks of stopping the cyclophosphamide therapy. Then comes the cyclosporin or the CNI. It's, as already mentioned, it is preferred in the difficult to treat nephrotic syndrome group. The dose is 4 to 5 milligram per kg per day. Due to narrow therapeutic window, we have to do the drug levels. The maximum duration, it's like 2 to 3 years. And if we are expecting a prolonged therapy, protocol biopsies should be performed. The efficacy is 60 to 90% patients will respond to cyclosporin. And the advantage over tacrolimus is that the suspension is available, so we can give in young children. The side effect profile is like metabolic complication, nephrotoxicity, hyperkalemia, hepatotoxicity, hypertension, and dyslipidemia. And the cosmetic side effects include gingival hyperplasia and hypertrichosis. Next comes tacrolimus. Tacrolimus is again used in difficult to treat nephrotic syndrome. Dose is 0.1 to 0.2. Drug levels has to be monitored. Nephrotoxicity, hyperkalemia, tremor, seizure, headache, diarrhea. In addition to that of cyclosporin, glucose intolerance and hypomagnesemia are common in tacrolimus. We have to monitor for the side effects, and again, protocol biopsy is indicated if the therapy is prolonged. Rituximab or the anti-B cell, anti-CD20 monoclonal antibody is given in difficult to treat steroid dependent nephrotic syndrome, and the patient is CNI dependent. It should be avoided in patient less than 7 years. The dose is given as slow infusion of 375 milligram per meter square, 2 doses 1 week apart. The reactions include the infusion reaction, serum sickness, rituximab-induced acute lung injury, and then the infections. PCP pneumonia, reactivation of hepatitis B or JC virus are non-side effects. Hypogamma-globulinemia is not uncommon. So before giving pre-dose, the immunoglobulin G levels should be done. Along with viral antibodies levels and total count and the liver function should be documented before starting rituximab. Post-therapy, we should document the B-cell depletion by CD19 counts after 1 week. Also, before redosing also, we have to do immunoglobulin level. If the patient is already on MMF, CNI, or any prolonged immunosuppression, if the rituximab is an add-on therapy, then we should consider quatrimoxor prophylaxis. Otherwise, routine prophylaxis with rituximab is not recommended. Coming to the supportive care. As you all know, nephrotic syndrome is a volume depleted state, and the patient is high risk of hypovolemia if the patient is having diarrhea, vomiting, and diuretic use. Symptoms and signs are similar to that of any other child with hypovolemia. We can do investigations of the hematocrit may be increased, and the biochemistry of the urine or the imaging can be done to document the hypovolemia objectively. Management include, we have to discontinue the diuretic. If the patient is hypotensive, we should manage as shock. Then we have to give adequate oral IV hydration and albumin infusion whenever required. One of the most important complication is the which we usually manage is the edema. The ISBN 2021 quantified the edema according to weight gain as less than 7% weight gain as mild edema, 8 to 15 as moderate edema, and more than 15% as severe edema. Whenever we are going to manage edema, we should ensure that the patient is not hypovolemic. We should assess the hypovolemia first and then only go for edema management. If the patient is having mild edema, salt restriction is preferred. If the patient is having moderate to severe edema, diuretics need to be given. The diuretics are given as follows. The initial preferred drug is the furosemide, which is given as oral drug to the dose of 2 to 4 milligram per kg. If prolonged use is expected, we can use potassium-sparing diuretic to support the potassium, prevent the hypokalemia. If the patient is not responding in 48 hours, then we can use the diuretic synergism with the thiazide diuretic, either metolazone or hydrochlorothiazide. The patient is still not responding, we can convert to IV furosemide with albumin infusion. The patient is refractory, then we can consider furosemide infusion. The with albumin. If the patient is still refractory, we have to go for ultrafiltration. While giving albumin, there is worsening of hypertension, respiratory distress, and heart failure. So ensure her urine output before infusion, slow infusion, followed by diuretic is preferred. Hypertension is relatively rare in nephrotic syndrome, which is steroid sensitive, usually association of steroid resistant nephrotic syndrome, which is seen in 30 to 60% in various cohorts of frequent relapsing and steroid dependent nephrotic syndrome. Initial drug preferred is AC inhibitor or ARBs. If the AC inhibitor ARBs are contraindicated due to the renal dysfunction or due to volumes, the unclear volume status, we can consider calcium channel blockers. We have to anticipate hyperkalemia, especially in combination with calcineurin inhibitors. Infection contribute to the major cause of morbidity and mortality in case of steroid-sensitive nephrotic syndrome. Rapid diagnosis and management is the key. To prevent the infection, we should diagnose and treat relapses early. Here comes the role of urine protein diary. Vaccination at the early feasible point, and routine use of immunoglobulins are not recommended. Coming to hypovolemia. Hypovolemia in steroid-sensitive nephrotic syndrome is either due to hypovolemia, acute kidney injury, is either due to hypovolemia or due to drug-induced. The prevalence is around 3.3 to 8.5% in a population-based study, and usually it is associated with SRNS, low albumin nephrotoxin, or infection. The management is often supportive and is usually reversible. RRT requirement is documented to the tune of 2 to 20%. Patient can progress to CKD when associated with steroid-resistant nephrotic syndrome, FSGS, or when there is nephrotoxin associated AKI. Thrombosis is not uncommon in steroid-sensitive nephrotic syndrome, even though it is associated with congenital nephrotic syndrome, SRNS, membranous nephropathy, or indwelling catheter, etc. To prevent thrombosis in case of steroid-sensitive nephrotic syndrome, we should ensure ambulation, avoid hypovolemia. We should ensure judicious use of diuretic and compression stocking. Routine prophylaxis are not advised. The patient is already in high risk of thrombosis due to some other factors, or the patient already had an event of thrombosis, then only prophylaxis is recommended. Now comes the bone health. As we all know, we usually give calcium and vitamin D for all cases of nephrotic syndrome. It does not support, this practice is not supported by the evidences. This should be given if the patient is deficient in, deficient. We need not supplement at the initial episode. In case of SRNS or infrequent or steroid dependent nephrotic syndrome, we are justified in giving calcium and vitamin D. Coming to important addition, what is in the current guideline is steroid to prevent relapses. Intermittent dosing of steroids are recommended to prevent relapse. The candidates as per the ISBN 2000 guideline are the frequent relapsing nephrotic syndrome or the patient with frequent relapsing nephrotic syndrome on long-term alternative therapy. We can give same dose daily for 5 to 7 days during fever or respiratory tract infection. According to KDIGO 2020, the patient has frequent relapsing nephrotic syndrome or SDNS. If the patient is long-term alternative therapy of prednisolone, or the patient is off steroid, we can give 0.5 mg per kg daily prednisolone in case of upper respiratory tract infection or other infection for 5 to 7 days. Another important thing is the stress dose of steroids. The patient who is on long-term steroid therapy for the initial episode or for relapses are at risk of HP axis suppression. So at the time of stress may not create adequate stress response. So if the patient has received more than 2 weeks of steroid therapy within the past 1 year, this usually occur in a case of every nephrotic syndrome, unless it is not relapsed after the first episode. We have to consider steroid stress dose. The dose recommended is 0.3 to 1 mg per kg per day, or we can give IV hydrocortisone 100 milligram per meter square, followed by 25 milligram per meter square 6th hourly. This should be given till the stress passes. Coming to the summary of my presentation, the ISPN 2021 and the KDIGO 2020 has translated recent evidences into clinical practice guidelines. Compared to the previous version of these guidelines, there is uniformity in the recommendations. Recording of proteinuria at home should be taught at the initial episode itself. The short-term steroids to prevent relapse in SD or FR is an important addition. Selection of steroid-sparing agent should be individualized. While using steroid-sparing agent, we should follow for the response and for the complication. So that's all. Thank you all.
Thank you, Dr. Christie, for that complete overview of the new recommendations. I'm sure that everyone listening would have benefited from it. Thank you so much. Next, we have another common problem that pediatricians face in their practice, that is hematuria. So let's go to the presentation. Are my slides visible?
Yes.
Thank you. So how do we approach a case of hematuria is going to be my talk today. So what is hematuria? Hematuria is a macroscope. It can be macroscopic or microscopic. Macroscopic or gross hematuria means reddish colored urine which is visible to our eyes. Whereas microscopic one means when there is more than 5 RBCs per hyperfield seen under the microscope. So when a patient comes to our OPD complaining that the urine is reddish in color, what should we do? So the most important step is to keep calm and follow the rules. Why keep calm? Because already the parents are going to be very worried. Blood coming out of any orifice in the body is scary, and more so when it comes in the urine. So when the parents are worried, it's even more important that we are calm and we follow the rules. What the rules are, I'll tell you in a short while. So the rule number 1 is that all that's red is not blood. So what looks red need not be blood, it could be something else. So how do we differentiate? Let's see. So the question is it really blood? So a very important investigation which would help us is to do a urine dipstick. The urine dipstick can detect hemoglobin, myoglobin, as well, so that is blood as well as hemoglobin and myoglobin pigments. It also can detect protein. It's based on the pseudoperoxidase activity of hemoglobin or myoglobin. And the procedure is very simple. You have to just dip the strip in the urine, tap off excess urine and read the strip at the recommended time, usually 1 minute. The procedure is usually explained on the back of this box. And it has 100% sensitivity and 99% specificity in detecting 1 to 5 RBCs per hyperfield. So it's a very good investigation to have. Urine analysis is definitive for the presence of RBCs. The procedure is to centrifuge 10 ml of fresh urine sample at 2000 RPM for 5 minutes, take off the supernatant and resuspend the sediment in remaining 0.5 ml. Examine the sediment under high power, count the RBCs in 20 fields and report the average. So persistent hematuria is defined as at least 2 out of 3 urine analysis performed over 2 to 3 weeks, and it warrants further investigation. So we have done a dipstick, we have done a urine analysis. So what if we have a positive dipstick reaction but absent RBCs? If we have positive dipstick and positive RBCs in urine microscopy, it is blood. But when we have a positive dipstick and absent RBCs, it could be hemoglobinuria or myoglobinuria, one of the pigments. So an easy test to do would be to centrifuge a fresh urine sample and see the color of the supernatant. In hematuria, the supernatant will be cloudy red or dark brown with RBC deposits. Whereas in hemoglobinuria or myoglobinuria, the supernatant fluid will be clear pink with no deposits. So if you have RBCs, there will be deposits. If you have hemoglobinuria or myoglobinuria, there will be no deposits, but the supernatant will be pink. Now add ammonium sulfate to the urine. If it clears, it is hemoglobinuria. If it persists, it is myoglobinuria. So next we have a possibility. The urine is still red, but both are negative. Lipsticks are negative. There is no urine. So then what could it be? So now we think of other agents that can color the urine, other pigments that can color the urine. And the list is a huge one. So I've given just some common things. So reddish or pinkish urine can have drugs like chloroquine, phenobarbital, beetroot, porphyrins. It can be dark yellow or orange in a normal concentrated urine or using rifampicin and pyridium. It could be dark brown or black while having bile pigments, methemoglobinemia, or homogenesic acid. And the list is much more. And whenever we see a particular color, we can always look up at the list. So we go to the next rule. Rule number 2, don't always blame the kidneys. Why I say that is because it's when you have hematuria, it is not always from the kidneys. It could be from the kidney, the upper urinary tract, consisting of the glomerulus, the collecting tubules, and the tubulointerstitium. But we have to always think of the lower urinary tract constituted by the pelvis, ureter, bladder, and urethra. So in practice, it could be anywhere from the kidneys to the tip of the urethra. So how do we differentiate whether it is a glomerular or a lower tract bleeding? So glomerular bleeding will be brownish or more cola colored, not bright red. It will be uniform colored urine. It will not have any clots. If you see under the microscope, all the RBCs won't look the same. They will be dysmorphic, meaning different shaped RBCs. There can be RBC casts. There can be associated proteinuria more than 100 milligram per deciliter. In addition, there can be associated edema, oliguria, and hypertension. Whereas the lower tract bleeding will be a bright red urine. We can expect that because it's a fresh blood coming out into the urine. It will be non-uniform. There may be like the blood may be coming out in the beginning or in the middle or towards the end. There can be clots. There can be terminal gross hematuria. In association, there can be irritative voiding symptoms, strangury. And under the microscope, all the RBCs will look the same. That is eumorphic RBCs. And there will be no associated proteinuria. To differentiate these two, we differentiate the site of lower tract bleeding. We can also do a 3-tube test in which the child pees and the urine is collected into 3 different test tubes consecutively. So if the bleeding is more in the first tube, then we consider urethra as the site of bleeding. If it is more in the second, it could be anywhere in the tract. But if it is a terminal hematuria, that is the 3rd tube is having more of blood, then it is bladder, especially the trigon. I'm sorry, my slides are not moving now. Yeah. So for the glomerular hematuria, we can have isolated kidney diseases as the cause or multisystem disorders. So the isolated renal diseases would be IgA nephropathy, post-infectious glomerulonephritis, Alport syndrome, thin glomerular basement membrane disease, or membranoproliferative glomerulonephritis. Whereas multisystem diseases will include SLE nephritis, HSP nephritis, Wegener syndrome, Goodpasture syndrome, hemolytic uremic syndromes, and sickle cell diseases. Extraglomerular hematuria can again be divided into an upper tract and a lower tract. So the upper tract would be pyelonephritis, ATN, papillary necrosis, nephrocalcinosis, thrombosis, malformations, sickle cell disease, tumors, polycystic kidney diseases. Whereas the lower urinary tract could be any cystitis, urethritis, urolithiasis, trauma, bleeding disorders, heavy exercise, uretropelvic junction obstruction, uretroceles. And one important cause that we always have to remember, though it should be the last of our differential diagnosis, is Munchausen syndrome, and in children, Munchausen by proxy. We do come across hematuria as a manifestation of Munchausen by proxy. I wouldn't say very often, but not very rarely. So this is just a recap of what we have discussed. When you have macroscopic hematuria, obtain a urine analysis. If there are no RBCs, look for heme positivity, which indicates hemoglobin or myoglobin. If there is no heme, you think of other drugs and pigments. Whereas if you have RBCs, again look at proteinuria. So if we have proteinuria, it is usually a glomerular disease. Without proteinuria, it is usually an extraglomerular bleeding. Rule number 3 is to listen to the story. So we really have to listen to what the patient and the parents are saying, because it mostly gives us a clue to the cause of hematuria. So from history, there might be recent respiratory infection or sore throat, which may be relevant in post-infectious glomerular nephritis, IgA nephropathy, and henoch-Schönlein purpura. Malar rashes, joint pains, abdominal pain may all be, or other rashes may all be seen in henoch-Schönlein purpura, SLE, or vasculitis. Recurrent gross hematuria may be seen in IgA nephropathy, PIGN, and Alport syndrome. Dysuria frequency, suprapubic or flank pains may be a feature of UTI, pyelonephritis, or stones. Recent treatment with NSAIDs can have, it may be a feature of interstitial nephritis. Trauma, history of trauma may indicate renal contusion. Another important history is that of recurrent hematuria. So it may be a feature of isolated renal diseases like IgA nephropathy, thin basement membrane disease, Alport syndrome, MPGN, FSGS, and anti-GBM disease. Multisystem disorders like SLE, HSP, HUS, vasculitis, Goodpasture's disease, HIV, and sickle cell disease can all present with recurrent hematuria. So the first question probably that you should be asking is whether you had a similar episode before. And sometimes patients don't give that history unless we ask for it. Recurrent hematuria can also be seen in tubular interstitial diseases like crystalluria, especially idiopathic hypercalciuria, pyelonephritis, acute tubular necrosis, papillary necrosis, nephrocalcinosis, etc. And also due to anatomic causes like polycystic kidney disease, multicystic dysplastic kidney disease, hydronephrosis, tumors, and trauma. Hematological diseases like sickle cell disease, coagulopathies, and thrombocytopenia can also present with recurrent hematuria. Also think of vascular causes like arterial or venous thrombosis, hemangiomas, and aneurysms. Rule number 4, family is very important. The family history is actually very important in hematuria. So what are the family history that we should be looking at? We should look at family history of hematuria, hearing loss, hypertension, kidney stones, renal diseases, renal cystic diseases, hemophilia, sickle cell trait, and dialysis or transplant. So suppose if someone says that the grandfather was hypertensive at 65 years of age, probably it's not very significant. But somebody says that we have like the uncles or even the grandparents or the parents are hypertensive at 25 or 30 years of age, probably you should think of some renal association for the hypertension. A hearing defect or visual defect in the family can be seen in Alport syndrome. History of microscopic hematuria in several family members may be because of benign familial hematuria or thin basement membrane disease, Alport syndrome, hypercalciuria, or IgA nephropathy. History of renal failure or dialysis may be found in patients with Alport syndrome, polycystic disease. Kidney stones, it may be familial due to hypercalciuria or hyperoxaluria. Sickle cell disease or trait, as we all know, can be all familial. So the next rule is that clinical examination is still very important. So the first thing that we have to look at during physical examination is to see if there is hypertension and target organ damage in form of papilledema, retinopathy, or LVAH. If blood pressure is normal and urine output is adequate, it is unlikely that microscopic hematuria, whatever be its cause, requires immediate treatment. But if we find blood pressure is elevated, it indicates that we have to act quick, we have to find the reason quick, and we need an intensive diagnostic evaluation and prompt management. Again, the slides getting stuck in between. So sorry for this delay. Yeah. So high blood pressure, as I said, it could be a non-specific renal disease, but which should accelerate our action. Edema may indicate proteinuria like in nephrotic syndrome due to any cause, minimal change, FSGS, MPGN, or membranous, or it could be a result of fluid retention in acute kidney injury secondary to post-infectious glomerulonephritis, IgA nephropathy, vasculitis, or SLE. Purpura, petechiae, rash can all be seen in HSP, SLE, and vasculitis. Costochondral with costovertebral angle tenderness or suprapubic tenderness may be a feature of UTI, pyelonephritis, or stones. Pallor or anemia can be a feature, it can be mildly dilutional, or if it is severe, it could be a feature of SLE, hemolytic uremic syndrome, and vasculitis. If you get an abdominal mass, we have to think of tumors, hydronephrosis, and polycystic kidney diseases. I don't know whether it's a network issue or a Zoom issue. Yeah. So the next rule is that diagnosis may be made in the lab. So hematuria is one condition which requires probably intensive laboratory support. So the initial investigations are simple. It requires urine analysis, as we discussed. So dipstick, which can detect heme, protein, and evidences of infection in the form of leukocyte esterase and nitrite. Microscopy to see the RBCs, its shape and presence of RBC casts. In blood, routine renal function tests like urea and creatinine, serum electrolytes, other tests like albumin, a complete blood count, and whenever indicated, ASO, anti-DNase B, C3 complement, ANA, IgA, and NCAM, and a renal ultrasound. So this is an RBC cast, which has to be looked for carefully because immediately then we will be restricted to glomerular causes for hematuria. So this is what I was describing as dysmorphic RBCs. You can see that these RBCs are having blood-like structures. So these are otherwise known as acanthocytes. They are ring forms with the vesicle-shaped protrusions. So this is like a Mickey Mouse cell. Imaging, ultrasound is usually the most important imaging test, and it is usually adequate, but it can sometimes miss stones. A plain abdominal X-ray is obtained when we suspect a stone disease. MCU is done in cases of urinary tract infections or suspected bladder pathology. IVP is occasionally helpful, especially for stones. CT scan is done when we have history of trauma or when we suspect stones or malignancy. MRI usually only in cases of malignancy. Isotape imaging, especially DMSA for scarring, GTPA for obstruction from stones, or to look at function in cystic diseases. So rule number 6, C3 is a very important investigation. Why? Because we can actually etiologically classify glomerulonephritis based on the C3 level. So C3 is usually done only when we think of a glomerular cause for bleeding, not when a lower urinary tract bleeding is suspected. So we can basically divide the glomerulonephritis into two forms. One is the low C3 and next is the normal C3. So low C3 glomerulonephritis include post-streptococcal glomerulonephritis, MPGN, lupus, infective endocarditis, shunt nephritis, some forms of atypical HUS, and C3 glomerulopathy. Normal C3 may be found in IgA nephropathy, HSP nephritis, vasculitis, anti-GBM disease, Alport syndrome, and the diarrheal associated HUS and even some forms of atypical HUS. Rule number 7. Whatever we have discussed are the common causes. Rare causes do occur and should not be forgotten and should always be in the bottom of our list. So these are some of the rare causes of hematuria. One is the nutcracker syndrome, which is caused by the compression of the left renal vein between the abdominal aorta and the superior mesenteric artery. Sickle cell disease, we have already said it leads to renal papillary necrosis. And when we have young girls, especially with recurrent hematuria, you always have to think of abuse, sexual abuse, or insertion of vaginal foreign body. Cyclical hematuria can occur in females with congenital adrenal hyperplasia and virilization, but who have been raised as males. There's something called a loin pain hematuria syndrome, in which there will be episodes of lumbar pain and macro or microscopic hematuria. This is actually a diagnosis of exclusion. The pathogenesis is unresolved, and luckily for us, it's rare in children. Then we have transient hematuria, which could be due to traumas, severe exercise, infections, drugs, toxins, or menstruation. It is related directly to the primary disorder, and it will disappear once the primary disease is resolved. So usually they do not need evaluation in detail. Just wanted to put in a word about microscopic hematuria and nephrotic syndrome. Microscopic hematuria can be observed in 20% of children with minimal change nephrotic syndrome. But a gross hematuria usually indicates it's a non-minimal change disease. So if you see microscopic hematuria, it might still be minimal change. So we just treat and wait. But if you see gross hematuria, we have to think that it's a significant lesion nephrotic syndrome and probably plan for a biopsy. So the next rule is, if in spite of all our investigations so far, we are still in doubt, the thing is to do a renal biopsy. So the indications for renal biopsy may vary depending upon the initial presentation. If it presents as glomerulonephritis, probably a normal C3, presence of rapidly progressive renal failure, or anuric renal failure, nephrotic proteinuria, or features of a systemic disease will be an indication for biopsy. If it's like a delayed resolution of glomerulonephritis, then as oliguria or ascitemia persisting for more than 2 weeks, macrohematuria more than 3 to 4 weeks, persistently low C3 for more than 8 weeks, or microhematuria or proteinuria persisting more than 1 year, we would probably like to biopsy. In addition to this, when we have recurrent hematuria, we tend to biopsy just to find a cause. The rule number 9 is that unfortunately we can't diagnose everything. In spite of all these investigations and in spite of a renal biopsy, there will always be a small percentage of cases for which we cannot find a cause for hematuria. So what to do when you find isolated microscopic hematuria? The most important thing is to keep under surveillance, not to lose the patient, and instead keep them under follow-up for the development of proteinuria or any other features which suggest an underlying disorder. Most of the times we see that the disease usually evolves, even though it starts as microscopic hematuria, it either evolves and develops hypertension or proteinuria, something which will give us a clue about the primary disorder. You can always take a early pediatric nephrology consultation, and you can follow up the patients in concurrence with the pediatric nephrologist. So I just end with some quizzes, since it's not like a person to person, like not a live conference. Probably I wouldn't be able to get your answers, but I just will run through some cases. So this is a child who has gross hematuria following an upper respiratory infection. C3 is within normal limits, but he gets gross hematuria every time he gets an URI. So what is the diagnosis? Diagnosis is IgA nephropathy or Berger disease, in which you will see IgA deposits on renal biopsy. The clue is that C3 is normal, so it's not infection related, or if not a PSGN. Elevated IgA levels are not done usually, and if you do it, you might see it only in 15% of cases. These children are often hypertensive. They may or may not have proteinuria, and they require long-term follow-up. The next case, this child was in our OPD 2 weeks back. Mother is calling and saying his urine looks like Coca-Cola. What's the diagnosis? So this is typically a staph infection or a strep infection, probably a strep infection because it was followed by cola-colored urine. So it's an acute post-infectious glomerulonephritis. The terminology right now is IRGN or infection-related glomerulonephritis. It's caused by the nephrogenic strains following infections of the throat or the skin. Most children luckily recover completely. C3 levels are low initially and then return to normal after 6 to 8 weeks. They can have hypertension, proteinuria, and microscopic hematuria can persist even up to a year after the initial presentation. The next case is a 3-year-old girl with sudden onset hematuria, but it cleared spontaneously in a day. There's no fever, no pain. On examination, there's nothing, but there's a history of father having kidney stones. So when we find this case, we always think of renal stone disease. So other than imaging, the child also requires 24-hour urine estimations for calcium, oxalate, citrate, uric acid, depending upon the type of stone. And also, sometimes metabolic workups are required. The next case is a 3-year-old child girl with diarrhea. 6 years later, develops a rash and abdominal pain. On examination, we note pallor and purpura, and this is what the peripheral smear shows. So we can appreciate the fragmented RBCs or the schistocytes here. So the diagnosis is obvious. It is hemolytic uremic syndrome, which is usually caused by a Shiga toxin producing E. coli, even though Shigella can also cause this. The next case is an infant comes with hematuria, the history of constipation, history of TF repair, tracheoesophageal fistula repair, there is polydactyly. So what is the diagnosis? So when we have so many anomalies, we think of vector association, whether we have vertebral anomalies, anal atresia, tracheoesophageal fistula, radial limb, and renal abnormalities. So they can be associated with renal abnormalities, which could have caused this hematuria. So this is a 14-year-old female with hematuria and also complaining of feeling more tired lately. So can we all appreciate this rash? So what's the diagnosis and what labs should be done? So diagnosis is SLE nephritis. The typical malar rash is the giveaway. C3 and C4 are the investigations to be done immediately along with the ANA profile. So C3 and C4 will be low. And sometimes it's important to know that SLE can manifest only as kidney disease and is usually picked up by the renal biopsy. And there's also a WHO staging of nephritis, which will determine the treatment. Next is an 11-year-old boy with gross hematuria and edema. Initial labs reveals low C3 and C4. So it's similar to that case earlier, but it's a boy now. So what's the diagnosis and how will we make a definitive diagnosis? So when we have an adolescent boy presenting with nephritis and with low C3 and C4, for a girl, we would think of lupus. For a boy, we will think of membranoproliferative glomerulonephritis. This is the most common cause of chronic glomerulonephritis in children, and it requires biopsy to diagnose. So just if we can't remember anything about conditions causing hyperchondroplasia, just think of PMS, which is post-infectious glomerulonephritis, membranoproliferative, and SLE. There are many other conditions, but these three would be the most common. So this is my last case. So it's 10 o'clock at night. We are sitting in SAT as the duty MO. MCH Ortho has unfortunately just consulted us on one of their patients who is 8 years old for hematuria. So we reached there, looked through the chart, and the only thing that we can make out is that he was in a car crash 2 weeks ago. We went to examine her, but nothing could be done because she's in a full body cast. And whatever we could examine, there was nothing much contributory, and it was a febrile. So what is the one test that we have to order before we walk back to SAT? It would be to do a urine calcium creatinine ratio, because prolonged immobilization we know that can lead to hypercalciuria, which could lead to hematuria. So a urine calcium creatinine ratio more than 0.2 is significant. And if it comes as significant, we can do a 24-hour urinary calcium excretion, for which the cutoff is more than 4 milligram per kilogram. The slide is not again moving, but I've come to the end of my presentation. Thank you everyone for your patient listening. If you have any questions, I'll be happy to take. Since I think we have no questions, we'll go to the next talk, which is an update on steroid-resistant nephrotic syndrome. Again, new guidelines have come for steroid-resistant nephrotic syndrome. To enlighten us, we have Dr. Rehna Ke Rahman, who is a pediatric nephrologist at Aster MIMS Hospital, Kozhikode. She has done her MBBS from Kozhikode Medical College, MD from Thrissur Medical College, and DM in pediatric nephrology from St. John's Medical College, Bangalore. Over to you, Dr. Rehna.
Thank you, ma'am. Am I audible?
Yes, you are.
My screen is visible, right?
Yes, yes.
Yes.
Okay. First of all, I would like to thank IAP Cochin and the IAP Nephrology chapter for giving me this opportunity. And last two talks was wonderful. I think we had an elaborate session on steroid-sensitive nephrotic syndrome by Dr. Christie, and such a nice session by Radhika ma'am. So after that, we'll be moving into the next talk, which is in fact not a very topic of interest for pediatricians probably, but it is at the same time the bread and butter as well as the biggest headache for pediatric nephrologists. What is the steroid-resistant nephrotic syndrome? A warm good morning to all my teachers. Many of my teachers are present here. Senior colleagues, friends, and postgraduates. So we'll move ahead with the presentation. As we all know, steroid-resistant nephrotic syndrome is one disease which does not carry such a good prognosis in long term, and which has long-term implications pertaining to kidney function. And it all bottoms down to the single cell, which is shown in the picture, that is the podocyte. That is a transmission electron microscopic view of podocytes with its nice food processes. So it is whole discussion, or the whole thing is hanging around this cell, which is just challenging us for years or so. So we recently guidelines have come. We'll go through the guidelines and in as brief way as possible. So the overview of my presentation would be concentrating on the definition of steroid-resistant nephrotic syndrome, how we will work up, and briefly about management. And the major part of my presentation would be based on these two publications which have come in 2020 and 2021. The top one is from the IPNA, that is the International Pediatric Nephrology Association Clinical Practice Recommendations, which has come in 2020. And the modified, the version of ISPN, that is the Indian Society of Pediatric Nephrology, which has come this year. So the major part of my presentation would be based on these two publications, which is freely available for any of yours further clarification. So incidence of nephrotic syndrome is around 12 to 16 per 1 lakh children, and around 10 to 15% of them can have a steroid resistant course. And out of them, around 20 to 30% may have a genetic mutation. And this varies depending upon various other factors like the age of onset, the family history, or the biopsy picture. So what is the definition of steroid-resistant nephrotic syndrome? So we had various definitions way back from 1990s, initially proposed by the ISKDC. Later, we had the ISPN definition in 2009, the KDIGO definition in 2012. So it was, it keeps on changing. From the ISKDC, it was like 4 daily and 4 weeks of alternate day steroids, whereas in ISPN it was just 4 weeks. And when it came to KDIGO, and as which is given in the Nelson, it was like 8 weeks. So this makes us quite confused. So what has happened or what is new? So the new, before going into new definition, I would like to stress on some points which has come in the latest IPNA recommendation, IPNA clinical practice recommendation. There are some terms rather which we should be clear before defining a steroid-resistant nephrotic syndrome. So the first thing is something called as a confirmation period. I will come into later. And the terms like complete remission and partial remission. And more importantly, both tests should be used for assessing remission. So these are the points on which the latest definition or the present definition is being framed. So which test has to be used? So both the IPNA as well as the ISPN guidelines suggest that, or recommends, it's not suggestion, recommends that urine protein creatinine ratio of the first morning sample or a 24-hour urine protein should be the preferable method of testing which you should use before branding a patient as steroid-resistant nephrotic syndrome. If these tests are not available, 3 consecutive urine albumin dipsticks can be used as an alternative. Now we move ahead with the definitions of complete remission and partial remission. So complete remission is the sample we already told, that is the urine protein creatinine ratio. And if it is between if it is less than 20 milligram per millimole or less than, commonly what we use is milligram per milligram. So if it is less than 0.2 milligram per milligram, that amounts to complete remission. If relying on urine albumin dipstick, it should be negative on 3 or more consecutive days. On the other hand, partial remission is defined as a urine protein creatinine ratio. It is more than 20 but less than 200 when the units are milligram per millimole, whereas in milligram per milligram, it should be between 0.2 and 2. And in partial remission, as per IPNA, a serum albumin also should have been increased. It should be at least 3. So these are the test and the definitions which is laid down by IPNA. So next comes to what is the confirmation period. So confirmation period is applicable only in patients who have a partial remission at 4 weeks. I already discussed what is partial remission. These people, those who have partial remission, they are subjected to a continuation of oral prednisolone plus RAS inhibition for 2 more weeks. That is a total period of 6 weeks. And in this interim period, we have to carry out a renal biopsy plus or minus genetic studies. And suppose if they go to complete remission at 6 weeks, they are branded as late responder, and again, they are considered as steroid sensitive nephrotic syndrome. So in a nutshell, what constitutes steroid resistant nephrotic syndrome? So there is slight difference between IPNA and ISPN. So according to IPNA, if there is a lack of partial remission at 4 weeks, that is a steroid resistant nephrotic syndrome. Or even if there is a partial remission at 4 weeks, if there is no complete remission at 6 weeks, that is after the confirmation period, it amounts to steroid-resistant nephrotic syndrome. The ISPN has made things simple so that to avoid the confusion of what is confirmation period or what has to be done in the next 2 weeks, ISPN now made things simple and has just kept it as failure of complete remission at 6 weeks. So there is slight difference, but overall it looks like in summary, it is the time point has been shifted from 4 weeks to 6 weeks. And definitely before diagnosing SRNS, we have to rule out common entities like drug non-compliance, drug interactions, and presence of infection. And one point to be noted is this definition for steroid-resistant nephrotic syndrome is applicable for both primary and secondary resistance. I hope it's clear how we will diagnose steroid-resistant nephrotic syndrome. So moving ahead with the workup. So when we have a child or a patient with steroid-resistant nephrotic syndrome, as in any other medical scenario, the workup starts with the history, clinical examination, followed by the lab investigations and advanced investigation. So in history, we have to concentrate on certain points like the age of onset. Age of onset, the younger, in early infancy, the more likelihood of having genetic etiology for steroid-resistant nephrotic syndrome. Family history, particularly sibling history, and history and a 3-generation pedigree chart is a must when you see a patient with steroid-resistant nephrotic syndrome. Then history of consanguinity, and a point to be stressed are you have to actively search for presence of extrarenal symptoms as well. Extrarenal symptoms can pertain to any system from head to bottom. It can be neurological symptoms, it can be ocular, it can be hearing or ear related symptoms, it can be developmental delay, can be bone related symptoms, short stature, dermatological manifestations. So a thorough search for extrarenal symptoms is warranted in a child with primary steroid-resistant nephrotic syndrome. Now, moving ahead with clinical examination. Clinical examination, we should look for in vitals, we have to concentrate on hypertension. And the routine clinical examination for the nephrotic syndrome findings as well as steroid toxicity has to be done. Apart from that, 2 things which I would like to stress are, again, searching for extrarenal features or what we call as pediatricians as syndromic features, and features of secondary nephrotic syndrome. Like, for example, secondary nephrotic syndrome in a context of lupus, where you can look for other stigmata of lupus, or secondary nephrotic syndrome in the context of chronic infections, chronic viral infections like Hep B or Hep C. So we have to actively search for findings supporting these in the child. And a few pictures which I have shown in this slide demonstrate various syndromic features. The top one is actually, the top one is a child with short stature and a disproportionate short stature, in fact, a short trunk dwarfism. And this is a child with spondyloepiphyseal dysplasia, which have an association with SRNS. And the eye picture shows microchoria. I don't know how much clear it is. And the below picture shows ambiguous genitalia. And the pictures on the left-hand side shows various pictures of nail dystrophy and X-ray images of iliac horns, hypoplastic patella, and subluxated radial head, which can be seen in syndromes like nail patella syndrome. So a thorough search for extrarenal features by history as well as examination is warranted in any child with primary steroid-resistant nephrotic syndrome. So moving ahead to the lab investigations, we can do innumerable investigations in nephrotic syndrome, but broadly we can classify them into 2 groups. That is the investigations to look for any features of secondary nephrotic syndrome, like as we already discussed, presence of complement C3 level, antinuclear antibody, viral serology, HIV, HBsAg, HCV, CMV, and a peripheral smear thrombocytopenia, basically for malignancy. Sometimes leukemias can masquerade as nephrotic syndrome, and HUS due to certain mutations can, like DGK mutation, can masquerade as nephrotic syndrome. So these investigations to look for any secondary nephrotic syndrome is one group. The second group of investigations are basically to look for complications lately of steroid-resistant nephrotic syndrome. And first and foremost out of them will be the renal functions or the GFR. So a creatinine, along with that other investigations like lipid profile, thyroid function, metabolic bone disease status, calcium, vitamin D, and an ultrasound, kidneys, and Doppler. If suspecting any thrombotic events, Doppler and all may be warranted. And in such scenario, more and more investigations may be needed, tailoring to the patient needs. But in general, investigations can be grouped into 2, that is to look for secondary NS and to look for complications of SRNS. So we'll move from the lab investigations to the advanced investigations, or in fact, what is the renal biopsy? So renal biopsy is indicated in all children with steroid-resistant nephrotic syndrome. And what we usually do is a light microscopy and immunofluorescence. They are definitely, they have to be done. Electron microscopy is not a must actually because of its cost and availability issues. But if you're suspecting any basement membrane disorders like Alport or any disorders with deposition, with immune complex deposition like C3G, they may be warranted. But unless otherwise, there is no must need for a electron microscopy. The common biopsy histopathological picture we see in children with primary SRNS is FSGS, focal segmented glomerulosclerosis, seen in around 56%. It is closely followed. It is followed by minimal change disease, which is seen in around 20%. Then there can be mesangial proliferative GN, which is seen in around 11%. A small around 3% shows what is called as a diffuse mesangial sclerosis. And this carries some importance in that diffuse mesangial sclerosis has an association with various certain genetic monogenic variation, monogenic mutations. So that carries the importance of detecting a DMS. Apart from that, sometimes biopsy may bring surprises in the form of diagnosing other causes of secondary nephrotic syndrome, like renal diseases, primary renal disease, IgA nephropathy. IgA nephropathy in children can present just like nephrotic syndrome also. And it can C3GN or membranous nephropathy or MPGN, these all sometimes come as surprises. But the common histopathology which we encounter are FSGS and MCD, and very small proportion having diffuse mesangial sclerosis. So next to the biopsy, we'll be moving ahead to the genetic screening. So we know that this is an everlasting list of new genetic mutations or variations which are being discovered day by day, which is being added into the armamentarium of nephrotic panel, what we call as a nephrotic panel. So it all started maybe some 20-23 years back with the discovery of nephrin in the Finnish variant of congenital nephrotic syndrome. And after that, this was followed by discovery of many genes, which most of them are being localized in the podocyte food process. But there are some certain genes which are not in the food process, directly associated with food process. But basically, there has been a number of genes which has come into scene. And as of date, I think around 90 genes has been discovered, which has a monogenic, which has responsible for monogenic SRNS. So we'll move ahead with what are the indications for doing genetic studies. I think this is already covered by Dr. Christie, but just to make it a little stress on it. So as per IPNA, that is the International Pediatric Nephrology Association, it tells that all patients with primary SRNS and congenital nephrotic syndrome needs a genetic study. But Indian Society of Pediatric Nephrology has refined it or made certain modifications so that a genetic test, which is a costly one, it should be fruitful when we use. So there are certain additional points which has been added, and which is like, okay, in congenital nephrotic syndrome, both recommendations are there. Both has given recommendation, but apart from that, ISPN has not given like a blanket recommendation for all patients, but it has made its own points so that investigation is not going to be futile. So that include all primary SRNS in infancy, those SRNS with extrarenal features, familial SRNS, and renal biopsy showing pictures, non-MCD, non-FSGS pictures like diffuse mesangial sclerosis, definitely a non-response to CNI, and definitely prior to renal transplantation. And either the recommendations does not tell about any indication for doing genetics in a child with late resistance. So next comes the question, what genetic test has to be followed? So we know genetic testing is complicated. So we can, to keep it very simple, we can look for multiple genes or we can look for few genes. So few genes can be single gene if you can pinpoint your diagnosis by phenotypically, if the child is like very characteristic of a particular syndrome, say like a syndrome with short stature and spondyloepiphyseal dysplasia, we are almost phenotype is very clear. Then we can look for single gene by Sankar sequencing, which has its own advantages. Its reading depth is more, its chance of identification of variations are more. Or we can go for panels like target PCRs. But in other scenario where your phenotype is not very clear, testing for multiple genes by clinical exome or whole exome analysis is preferred. And either both of them have their own pros and cons. Single gene by a Sankar may be targeted only towards a certain genes, and we may miss any other things. Whereas if you are looking at multiple genes, new yield, new mutations, or new findings, surprising findings may be detected. So either of these have, both of them have their own pros and cons, but what commonly we do is a panel or a target PCR for the panel, nephrotic panel genes, unless we have a proper phenotype described beforehand. So what are the common genetic mutations? So as we can see in this picture, the bar diagram on the right side very clearly depicts that the chance of detecting a genetic mutation or a monogenic cause for SRNS depends on the age of the presentation. So you can see that it's around 70% in a child, in a baby that is in the group of congenital nephrotic syndrome, the first 3 months of life. It comes down to 50% in the late infancy, and it gradually comes down by adolescence to around 10%. And the mutations or the genes which are found to have mutations are also different depending upon the age group. So infants and less than 1 year usually have these 5 genes, that is NPHS1 nephrin, NPHS2 podosin, the LAMP2, WT1, and PLC1. Whereas in the 1 to 10 years, in the early childhood years, again NPHS2, that is podosin, is the most common genetic mutation, closely followed by WT1 and LAMP. Whereas in adolescence and young adulthood, other mutations, the genes are different. Podosin and NPHS1 are not there. The other genes like informin, ACTN4, TRPC6, and WT1 is one which has been seen in all these age groups. And majority of the genes which are responsible for monogenic SRNS are inherited as autosomal recessive in an autosomal recessive manner. But there are some genes like informin, ACTN4 and all, which have an autosomal dominant mode of inheritance. And those which have an autosomal dominant mode of inheritance usually present in late adolescence or young adulthood rather than in the infancy or early childhood. Now, a point to be noted is, I already discussed about this, that we have to do a thorough search for extrarenal features in a child with primary steroid-resistant nephrotic syndrome to look for various syndromes like WT1 mutation, which can cause a Dennis-Drash syndrome or Frazier syndrome. They can have a pseudohermaphroditism, which may be externally present in the form of an ambiguous genitalia. Risk for Wilms tumor and gonadoblastomas may be there. And these syndromes differ in the type of mutation and the age of onset of nephrotic syndrome and progression. Dennis-Drash presents much earlier, Frazier syndrome presents in the late childhood. So this is it depends upon the mutation. The variation depends upon the difference in the mutations. A LAMP2 mutation causes what is called as a Pearson syndrome, which causes syndrome, causes findings like dysplastic nails, absent or hypoplastic patella, and ocular manifestations like glaucoma. Then there is a group of mutations which pertain to the mitochondrial pathway and coenzyme Q deficiency, which can have neurological manifestations like sensorineural hearing loss, neurological issues like seizures, ataxia, and retinopathy. Then there is the Galloway-Mowat syndrome, which present with microcephaly, intractable seizures, and mental retardation, and mutation of WDR7 and KEOPS. Then you have acute myoclonus renal failure syndrome, which is characterized by myoclonic epilepsy and DCM. Then we have the Shimke immunohistodysplasia, which is characterized by T cell abnormalities and short stature due to spondyloepiphasic dysplasias. There are many others, including skin manifestations, non-syndromic and all, but to keep it in a nutshell, there are certain syndrome and the syndromic features should always be actively searched for in a child with primary SRNS. Now, one thing to be noted is that though we search for syndromic features and extrarenal features, there is something called as a phenocopy for SRNS, which has come into attention by the recent genetic studies. Recently, there has been an increase in doing genetic studies. So something called phenocopies have come to attention. Phenocopy is nothing. It just means that the child or the phenotype is like a nephrotic syndrome. The phenotype of that particular patient is like nephrotic. Phenotypes are similar, but the genotype or the genetic variation is in a gene which is not usually responsible for nephrotic syndrome. It is in some other gene. For example, Alport is a phenocopy for nephrotic syndrome. Similarly, Den's disease, CLCN5 is a phenocopy. Similarly, CTNS, that is cystinosis, is a phenocopy. So their phenotypes may resemble, but genotypically they are totally unrelated. They are not part of the nephrotic gene panel. But nowadays, genetic labs have included these phenocopies or also into the nephrotic panels, and many of them covers these phenocopy panels also. So it is just to bring into attention, there can be phenocopies which have a similar phenotypic presentation, but the underlying genotype is totally different. Underlying genotype is not related to any podocyte or any nephrotic related genes. It is something else. So this has been unraveled by the genetic studies. Otherwise, this may not get unraveled. So what is the rationale for doing genetic investigation? So genetic investigation, I'm just stressing because this is important in a primary SRNS. So we know that a molecular diagnosis, planning, evaluation, and monitoring, and definitely identifying phenocopies. Because phenocopy, if you identify an Alport and all, there is no point in giving a immunosuppression or the entire management, the counseling, everything changes. Prognosis counseling, informing about the therapeutic unresponsiveness, treatment decisions. And one point to be noted is that certain genetic mutations like coenzyme Q and Cubilin mutations, if found sufficiently early, were found to have a improvement with the coenzyme Q supplementation. So there is the unraveling of genetics has resulted in some therapeutic options as well. Counseling about transplant outcome, donor identification, and importantly, antenatal counseling and planning the next pregnancy. So genetic investigations properly, if we use, it has an important role at multiple levels. So with this, we'll finish the management. We will finish the workup. We'll move ahead with the management. Management I've kept as brief as possible. So broadly, we can group it as immunosuppression, non-immunosuppressive therapy, supportive care, monitoring, and managing drug-related adverse effects. So immunosuppression, we know that calcineurin inhibitors are the first line. We can either tacrolimus or cyclosporin, which is already dealt by Dr. Christie. So there is no difference in any effectiveness, any maintenance of remission between tacrolimus and cyclosporin. But tacrolimus is preferred because of its less side effect profile. And but we may have to give cyclosporin in younger children because it is only available in it is the only drug available in a syrup or a suspension formulation. And following the calcineurin inhibitors are followed by IV cyclophosphamide. IV cyclophosphamide, but not oral cyclophosphamide, has been discussed in the present guidelines. IV cyclophosphamide given at a dose of 500 to 750 milligram per meter square monthly pulses has shown to cause remission in around 10 to 20%. And this is followed by rituximab, and that is a chimeric antibody, anti-CD20 antibody, and the recent addition of ofatumumab, which is the humanized anti-CD20 antibody. Rituximab is given at 375 milligram per meter square weekly doses and targeting a CD19 level less than 1%. Mycophenolate mofetil per se does not have any role in SRNS. Usually it is added as an adjunctive therapy along with calcineurin inhibitors or along with rituximab. So per se, as a single drug, MMF does not have much role. And one point to be noted is that prednisolone is also continued for 6 to 9 months along the calcineurin inhibitors, and they're slowly tapered and stopped by around 9 months. What is the recommendation by IPNA is that we have to ideally monitor CNI levels, that is a CNI trough levels, and we should continue the drug even if the patient has shown partial remission also. And when we call a patient as CNI resistant, suppose there is non-response, that is lack of even a partial remission at 6 months of therapy with adequate blood trough levels of CNI, we call them as CNI resistant. And if there is no response to CNI plus other agents, we call them as multi-drug resistant nephrotic syndrome. So this particular picture shows the response to immunosuppression. So we can see on the topmost where we have the CNI calcineurin inhibitors, whose response complete remission is in around 30%. And when you combine complete and partial, it comes to around 50%. Whereas you see the second one, that is cyclophosphamide, it is only around 10 to 20% if you take the complete and partial remission together. Rituximab is another drug which has shown relatively better response, around 30% is showing a complete remission. So why we are so much worried about complete remission and partial remission? Because both has its own implications on renal survival. This survival analysis diagram clearly shows that the topmost graph, that is the green one, in those is the graph of those who had complete remission. In them, the 10-year, 15 years renal survival is around 94 to 95%. Whereas those who had partial remission, the 10-year renal survival is of around 75%. And in those who had no response or no remission, the 10-year renal survival is around 30 to 35%. So even partial remission has a role in drug refractory or primary SRNS. So non-immunosuppressive therapy still lingers around AC inhibitors or ARBs. Some experimental or recent drugs like sparsentan, which is a dual blocker, dual endothelin and ARB, has shown some evidence, but doesn't have any evidence in children. Some experimental therapies like mesenchymal stem cells and retinoids are also ongoing. But if bottom line, it comes to only AC inhibitors or ARB, this should be given as supportive care in all children with primary SRNS. And it has known to reduce proteinuria by around 30%. But the problem with this is that if the GFR goes below 60, you have to be very cautious. If GFR is coming below 30, you may not be able to use it. So this is the main issue with AC inhibitors. Now a word about something new which has come, that is the LDL apheresis. So we know that steroid-resistant nephrotic syndrome is a stage with dyslipidemia. And when you have a dyslipidemia for extended periods, it by itself can cause nephrotoxicity and chronic progressive glomerular and tubular interstitial injury. So there has been some trials, some studies, non-randomized, just observation studies, which has been done, wherein they have used LDL apheresis, that is removing the LDL by using adsorption, that is dextran sulfate cellulose adsorption. There is a schedule like twice a week and then followed by a tapering schedule. And along with steroids, it has shown that some studies have shown that there is a decrease in lipids, but there is no decrease in proteinuria. And in one particular paper, they tell that there is a complete remission, but this is a very anecdotal evidence, not a very proven or I think more large scale prospective studies are needed, just to mention that there is such an entity called LDL apheresis. Now, just summarizing treatment, we know that any steroid-resistant nephrotic syndrome needs an extensive history taking, a clinical examination, kidney biopsy, and genetic testing if in specific situations. If monogenic, you continue with AC inhibitors, ARB, supportive care, and counseling and preparing the family, genetic counseling for antenatal diagnosis of next child, or in those pathway we have to move. Suppose it is non-genetic or there is no genetic test is not indicated. We can start CNI with tapering steroids, AC inhibitors, ARB, and supportive care. And if there is a good response at 6 months, you continue CNI for 2 years approximately. You can taper and stop steroids and monitor GFR, monitor drug adverse effects. And while doing well on CNI, or if it's sustained remission on CNI, many children show steroid sensitiveness. Later they start behaving as steroid sensitive nephrotic syndrome. In that case, we can give steroids. And if they goes into complicated course like steroid dependent, we can go for other drugs like MMF or rituximab. Suppose there is a non-response to CNI, you have to rule out genetic disease. At that point, genetic testing becomes mandatory. And then if it's again negative, genetic is negative, you can go for rituximab, CNI, or it can be combined with MMF also. If in remission, the pathway changes. But if again no non-response, what we call as a multi-drug resistant nephrotic syndrome, we can probably withdraw immunosuppression, or in fact, they tell that they can be recruited into clinical trials like LDL apheresis trials or whatever. So basically, it is the supportive care only comes to play in that group. So briefly about supportive care, I think Dr. Christie has already covered. So there are various issues ranging from hypertension, edema, dyslipidemia, hypothyroidism, growth failure, obesity, bone health, diet, immunization, infection, and more importantly, counseling and psychological support for the family and the child. So just briefly about few things which Dr. Christie has not mentioned. One is
Rahana, you are muted.
Sorry, ma'am.
Yeah, start with dyslipidemia.
Okay, sorry, I didn't notice it. Okay, so dyslipidemia, as we already saw, it by itself is a nephrotoxic entity. It can cause glomerulosclerosis and proximal tubular damage and cause CKD progression. So we have to manage dyslipidemia initially with non-pharmacological measures, that is dietary and physical activity and reducing screen time. So dietary, we advise the child 1 and child 2 diet. That is, child 1 stands for cardiovascular health integrated lifestyle diet. It is nothing. It just indicates reducing your saturated fat intake to less than 10% of your total calorie in the child 1 and less than 7% in child 2. And if that is not working, can go for a medical therapy with statins. And the indication they discuss in the IPNA recommendation is an LDL more than 160 or LDL more than 130 with other cardiovascular risk factors. And when you start statins, it is not actually approved below 8 years. So usually children above 8 years are being started on statins, and you have to closely monitor for any transaminitis and any muscle related symptoms. Now coming to hypertension, around 30 to 60% have hypertension, and the target BP which we have to achieve is between 58 to 75th centile. And those who have an ongoing proteinuria, it is better to achieve 50th centile. Again, start with non-pharmacological measures like salt reduction, lifestyle changes, drug therapy. ACARBs are the first line. And particularly if they are in CKD, those who have non-renal metabolism, that is ramipril or ARBs are preferred. And it is followed by calcium channel blockers. Another thing which is particularly important in SRNS is hypothyroidism. Protracted proteinuria and loss of thyroid binding globulin, transthyretin, and albumin can result in low levels of thyroid hormones. And a study from JIPMA showed that, in fact, subclinical hypothyroidism is more common, around 33% compared to overt hypothyroidism. So we can supplement with thyroid hormones if we are not achieving any remission of proteinuria beyond 3 weeks. Immunization, I think already Dr. Christie has covered this point, and we have to avoid live vaccines. And the special vaccines which we usually give are pneumococcal vaccine, varicella, inactivated influenza vaccine annually. One point I would like to stress is many of these children show weaning of their anti-HBs titers as they go on. We know that our primary immunization almost covers hepatitis B universally, but still they may have weaning of titers and may need a revaccination with hepatitis B, which is something which we have to keep in mind. Now, SRNS, the story does not end. In refractory SRNS, they can progress to...
Dr. Rayana, can you please wind up, because...
Yeah, it's over. It's the last slide. So the story does not end. These children may need a ongoing care and transition of care to adult nephrology, and may meet multiple issues in the future. Thank you for the kind attention. It's over, ma'am. Thank you.
Thank you so much, Dr. Anna, for making a difficult topic palatable for the pediatricians and simplifying everything so that we just know how to manage the SRMS. So next we have a very much awaited.
Radhika, there are a few questions in the chat box. Just put them across to Rana.
Okay, so one of the question is there an indication for genetic testing in secondary resistance? Dr. Anna?
Yes, ma'am. No, actually, there is no indication. Both for IPNA as well as ISKN does not recommend genetic testing in secondary resistance. It's not indicated.
The next question is, can we give varicella vaccine while on immunosuppressants?
As of now, the recommendations tell no. But there are certain studies from Japan and all where they have given varicella when you are on a very small dose of steroids, that is less than 0.5 mg per kg alternate day. And there has been no like acute events or complications. But both of our recommendations clearly tell no live vaccines while on immunosuppressants.
Thank you. Since we don't have any more questions, we go to the next talk, which is on a topic which we should all be knowing, because it's not really clinical, but it's about an investigation that we all order very frequently. It is about renal ultrasound in pediatric nephrology. And to talk about that, we have Dr. Shilpa Radhakrishnan, who is a pediatric radiologist at AIIMS Kochi. After completing DNB radiology, she has completed her fellowship in pediatric radiology from University of Alberta, Canada. She has 5 publications to her credit. Dr. Shilpa, over to you.
Sorry, I just started speaking without unmuting. Am I audible now?
Yes.
Okay. So yeah, thank you for that introduction, and I'll dive right in. The topic for me for today morning is pediatric renal and urinary tract ultrasound. It is a rather broad topic, and what my objectives are to kind of brief you about the utility of ultrasound, what its limitations are, when do you move on to further investigations and other modalities, what the challenges are in acquiring good images in pediatric ultrasound, and kind of try and let you know how to interpret the different radiology jargons that we churn out in our reports. So ultrasound KUB is the most common request that comes to our department. Ultrasound is a very good screening tool, a very good and sometimes the only diagnostic tool we need for a KUB evaluation. And it is also a good tool for guidance for intervention. It is easily accessible. It's a real-time investigation with excellent resolution. But the problem is that it is highly subjective. It's user-dependent and it's also patient-dependent. So children, they have to cooperate, their body habitus, their positioning, everything affects the kind of image that we get and how far we can interpret those images. And subjectiveness on the user part, the person has to be used to imaging children. They have to be comfortable imaging patients in that age group and know what to look at and how to interpret those differences in appearances that are unique for children. For example, neonatal kidneys appear different from other age group kidneys. So you have to be aware of that and not interpret that as abnormal. And changes occur as the child grows over time. There are changes in appearances that occur in the kidneys and the renal tract. You have to be aware of that. So when you're looking at ultrasound, what all do you look at? As a basic, renal size, very important. And one of my particular pet peeves is measurement of renal size. As we all know, the renal size is affected by the age of the patient, the sex, height and build of the patient, and ethnicity. And importance in pediatrics in a measuring renal size is that you have to make sure if you are following up a child, you have to make sure that there is adequate interval renal growth. For this, you have to make sure that you are consistently measuring the kidney on a reproducible plane in a reproducible approach. So I prefer the prone approach to look at the kidneys and measure the size, and this has been shown to correlate more with actual measurement. Supine measurement, insinuating from the sides along the flanks and sometimes increase the renal size. So instead of looking from the supine aspect, prone imaging can be useful, and that kind of ensures that your respiratory phases also do not much affect your size. So renal size is important. There are a lot of charts that you can refer to, and using the centiles for giving the renal measurements is very useful for the clinicians when you're following up a child to ensure that there is adequate renal growth between scans. Because if there is not, it means that something's going on somewhere. Maybe it's nutrition, maybe it's metabolic, something's going wrong. And also if you're looking for compensatory hypertrophy of an unaffected kidney, is that happening as well? Then we look at the echogenicity of the kidney, usually by comparing that with the echogenicity. Point to remember is that neonatal kidneys are brighter and usually become adult-like or older children-like only by around 6 months of age. And if they are preterm, that means they are more echogenic and it takes longer for them to normalize or have an adult appearance. Then, along with the echogenicity, we look at the corticomedullary differentiation, whether it is lost, preserved, reversed, accentuated, etc. Urinary tract dilatation, obviously, we look at the pelvis, the calyces, the ureters, and the bladder is an important thing to look at. Bladder volume, wall thickness, you assess pre and post void images. There are lots of formulas that you can use to calculate normal bladder volume. So these are just two images of an older child and a neonate, whereby you are measuring the sagittal maximum length. As you can see in the image, the neonatal kidneys are more echogenic or brighter with rather thinner cortex, and the hypoechoic medulla occupies most of the space there. So this should not be misinterpreted, should not be called as abnormal, because this is normal for a neonate. And these are just three images showing the renal sizes in supine, lateral decubitus, and prone positions. There are slight differences in the length. I don't think it's evident on the images, but there are differences in the length as measured on each different imaging planes. And like I said, I prefer the prone imaging because it's more consistent and reproducible when you're following up a child. The most common indication for ultrasound KUB is congenital abnormalities of the kidney and the urinary tract. And the most common request is a postnatal evaluation of antenatally detected abnormality. And of that, urinary tract dilatation is the most common. So postnatal investigations should be performed when there is a renal pelvis dilatation in the fetus of more than 5 mm seen after 34 weeks of gestation. The causes of urinary tract dilatation could be various, the most common being PUJ or BUJ obstructions, vesico-ureteric refluxes, posterior urethral valves, uretroceles, or other distal tract obstructions. So the newborns who have been detected to have urinary tract dilatations in the antenatal scans should have their first ultrasound in the first week of life. If you are suspecting PUV, if there is severe bilateral urinary tract dilatation with ureteric dilatation, or if there is oligoamnios, the ultrasound should be done within the first 24 to 48 hours of birth. In all others, it should be done, and that's the important point, after 3 days and within the first weeks. Thereby, you are avoiding calling it normal in the first 2 days, where there can be physiological oliguria and dehydration, so the system collapse, whereas in fact there might actually be a component of obstruction. So for all other children, it is better to wait for the first 2 days to be over, and after the third day you can image, unless it is a severe hydronephrosis or you are suspecting PUV or there is ureteric dilatation on the antenatal scan. If the first ultrasound is normal in the first week, they should have a repeat ultrasound in the next 4 to 6 weeks to ensure that it is indeed normal. So when you're doing the ultrasound, what all do we look for? You are looking at calyceal and pelvic dilatation, ureteric dilatation if it is there, presence of any cortical cyst, the echogenicity of the kidney, bladder wall abnormalities, presence of uretroceles if any, and the amount and degree of bladder emptying. If there is unilateral or bilateral urinary tract dilatation of more than 10 mm, or ureteric dilatation, and MCU is recommended as the next step to rule out the psychoureteric reflex. And once VUR is excluded, the next step is an exploratory study to look at obstruction of the renal tract. So the most common measurement that everybody follows is the renal pelvis APD diameter. And that kind of prognosticates and tells you what to do next and what treatment protocol to follow. The problem and some issues with renal pelvis APD diameter is that it is dynamic measurement. The measurement changes depend upon the degree of hydration, the degree of bladder distension, the position of the child, whether supine or prone, the degree of inspiration, etc. So it's fraught with some disadvantages, but it is still the most reliable measurement that you can depend upon. But you just have to know that there are some dynamic changes that occur in this measurement. So this is just the urinary tract, the UTD classification, the grading that is followed generally, which grades it into 1, 2, and 3, depending upon the degree of dilatation, whether there is central or peripheral calyceal dilatation, is there ureteric dilatation, how is the parenchyma, etc. The basic intention of these classification is to recommend what the next step is. What is the treatment protocol? When do you image next? What do you do? Do we need additional imaging? How do you follow up, etc. So this is a normal postnatal ultrasound in a child where you see there is some prominence of the pelvis. There is no calyceal dilatation. The pelvic dilatation is less than 10 mm. This is normal for the child. The parenchymal echogenicity is normal. You ensure that there is no ureteric dilatation and bladder emptying is normal. So this is normal. This as opposed to these grossly abnormal pictures, which are basically 1, 2, and 3 grades of the urinary tract dilatation. In the first picture, you have pelvis dilatation with central calyceal dilatation, and then you have more peripheral dilatation. And on the last picture, you have gross dilatation with parenchymal thinning and cyst formation. So over the years, a lot of classification or grading systems have been developed to try and classify urinary tract dilatation. The SFU system is the one that is followed antenatally by the Fetal Medical Foundation. And then you have the radiology system, the UTD system, and more recently, the Onan classification. All of this basically intends to prognosticate and suggest recommendation for further follow-up and treatment protocol. I'm sure all of this is going to be covered in the panel discussion next. I'm not going to go into any details. The next indication for ultrasound will be other antenatally detected congenital abnormalities, renal ectopias, abnormalities in position, duplications, whether simple, complete duplication or partial, dysplasias, cystic renal changes. These congenital abnormalities can be syndromic or non-syndromic. Even non-syndromic sometimes are said to be linked with some genetic associations. So talking about cystic renal disorders, mostly these are detected antenatally or during workup of neonatal renal insufficiencies. Cystic renal disorders can either be hereditary or other dysplastic conditions like multicystic dysplastic kidney or a cystic dysplasia. The hereditary ones are generally the ciliopathies and those associated with phacomatoses, the most common ones being tuberous sclerosis and von Hippel-Lindau disease. Mutations like DICER1 mutation are also associated with cystic renal diseases. So what do you look at when you are evaluating on the first scan of a cystic renal disease? Specifically, you're looking at the size of the cyst, whether micro or macro, how many are there, where are they located, which is cortical, subcortical, medullary, corticomedullary junction. Kidneys per se, are they large or small? How is the intervening renal parenchyma? Is it normal or is it looking abnormal? How is the echogenicity? Are both kidneys affected or is it single kidney? And extrarenal abnormal. So at that time, your ultrasound is not limited to the urinary tract. You have to look at the other organs. Are they extrarenal cysts? Are other organs involved? Particularly, a lot of these conditions are associated with liver fibrosis, portal hypertension, etc. So liver is an important organ to look at. So like this is just a list of all the cystic renal diseases that can occur either in the neonatal period or in the pediatric age group. There are some tumors with cystic elements, which I'm not going to talk about today, and other causes of acquired and congenital renal cysts. So these are just different pictures of different kinds of cystic renal diseases that we may encounter. This picture shows you the location of the renal cyst that can differ in different conditions. So that is subcortical, this is corticomedullary, this is medullary. And here you can see the difference in renal sizes between different entities. the degree of cortical echogenesis is different. This is normal, this is grace. Here there is complete loss of CMD. Here there is preserved. Here it is accentuated that the medulla appearing more hyperechoic. So these differences and these constellation of findings can sometimes help us, can lead us towards one particular diagnosis or tell us that it is not this, it's not ARPKD, it looks more like a medullary cystic or glomerulocystic. So it can kind of help us to lead us towards one particular diagnosis. So like I said, ultrasound is not limited to the kidney evaluation. We have to look at other organs, particularly liver, to look for liver cysts, biliary ectasia, signs of fibrosis, any signs to indicate portal hypertension. And also in female patients, you have to evaluate the internal genitalia because a few of these conditions and syndromes are associated with Mullerian duct anomalies. Like I said, a lot of these ciliopathies are syndromic and associated with extrarenal manifestations. So when there is a strong suspicion, you have to broaden your outlook, look at the child in total, see if there are other system involvement, nervous system, situs involvement, skeletal involvement, etc. And a lot of these ciliopathies are syndromic. Moving on to other cystic diseases, multicystic dysplastic kidney. This is a typical appearance of how it would look. A cluster of grapes kind of appearance of multiple cysts of varying sizes, non-communicating cysts kind of replacing the renal parenchyma, with the intervening parenchyma appearing or the stroma appearing quite echogenic. In children with unilateral cystic dysplasia or multicystic dysplasia, one thing you have to ensure that there is no associated other anomalies like a VUR and or obstruction in the contralateral kidney. The contralateral kidney, as you are following up, should be monitored to ensure that there is continued and appropriate compensatory hypertrophy. So this kid with an unilateral MCDK is being followed up. Then two things you look for. One, to ensure that it is involution of that but involved kidney, it reduces in size, and the opposite kidney, compensatory hypertrophy is occurring. Some cases of multicystic dysplastic kidney may be a hydronephrotic variety of multicystic dysplastic kidney. So if there is ongoing obstruction, especially if there is an associated erythrocyte or something, that involved kidney might not involute over time. So we recently, a couple of months back, had a case of multicystic dysplastic kidney that was being followed up but not involuting, and we found out that there was a erythrocyte actually, and after deroofing of that erythrocyte, that kidney continued to involute. So you have to look for associated anomalies associated with that. Like I said, other urinary tract abnormalities can coexist and needs to be ruled out. Cystic dysplasia can usually involve the whole kidney, but can sometimes be segmental in nature, or if it is a duplex kidney, can just involve one moiety. It also can occur in isolation or in association with other syndromic or chromosomal abnormalities. ARPKD is your prototype cystic renal disease, usually detected prenatally. The appearance is rather typical of a very large kidney, echogenic, with loss or reversal of CMD, with cortical and medullary tiny microcysts and tubular ectasias. And if you use high frequency, high resolution imaging, which is very important in small kids and neonates, you can see that typical small microcysts and tubular ectasias. And again, in this case, in this condition also, hepatic imaging is very important to look at hepatic fibrosis, Caroli's association, or biliary ectasia. The correlation between renal involvement and liver involvement is not proportional. They can be of a different, it related, but not always. And if in surviving kids of ARPKD, annual follow-up imaging to look at the liver to ensure that there is no or if there is a development of portal hypertension should be done. ADPKD in the pediatric population can be clinically silent, and sometimes it is only picked up in your screening a family with a positive history, or you're working up a child with hematuria or hypertension, and sometimes incidentally detected. In children, in patients less than 50 years with the positive family history, the presence of at least one kidney cyst and renal enlargement above the normal range, or both together, should be considered highly suggestive. Sometimes the renal size initially can be normal, even though enlarged kidney is the hallmark. And there the cysts are macroscopic cysts, and the intervening parenchyma will be normal. A very early onset type of ADPKD is there, which can be seen as hyperechoic enlarged kidneys either prenatally or in the neonatal period, and the appearance can mimic other cystic diseases like ARPKD. So other cystic diseases like medullary cystic diseases or glomerular cystic diseases, some differences are there in their appearance or could be there in their appearance on ultrasound. Juvenile nephronophthisis usually is seen as a normal sized or a small sized kidney with increased echogenicity. Cysts are not mandatory, but if present, they will be seen in the corticomedullary junction. Again, nephronophthisis are also sometimes associated with syndromes. So when you're suspecting, you have to look at the baby in total, look at other systems, including eyes, CNS, etc. And they also should undergo liver imaging to look for signs of liver fibrosis and portal hypertension. So this is a case of nephronophthisis where you have a rather normal sized kidney which is very echogenic with loss of CMD and cyst formation in the corticomedullary junction. This is a case of tuberous sclerosis where you can see parenchymal echoes are normal, but there are multiple parenchymal cysts and tiny hyperechoic foci are seen scattered throughout, which represent angiomyolipomas. Now moving on, ultrasound is a very useful tool when you're evaluating renal insufficiency in the neonatal period. So like I already said, cystic renal diseases might be a cause of renal insufficiency. So ultrasound here will help you rule out a lot of conditions as a cause of renal insufficiency, which can either be congenital or acquired. So renal diseases, you can rule out obstructive uropathies. If there are infections associated, are there any complications related to the infection, renal agenesis, and other parenchymal diseases are generally giving a non-specific appearance on ultrasound, basically causing increased parenchymal echogenicity. Such conditions like general renal parenchymal diseases, AC inhibitors, pituopathies, cortical necrosis, and all just produce increased parenchymal echogenicity. The mostly causes of parenchymal causes of renal insufficiency in neonates are usually pre-renal causes like hypoxia, hypoperfusion, systemic sepsis, heart diseases, prolonged positive pressure ventilation, etc. For them, the appearance on ultrasound can be non-specific with increased echoes. Initially, the size will be normal, and over time, it can shrink and cortical thinning might set in. Another abnormality that we very frequently see on neonatal ultrasound is medullary echogenicity. The point to note is that this medullary hyperechogenicity does not always mean medullary nephrocalcinosis. It's not synonymous. This list is a list of conditions that can cause medullary echogenicity other than nephrocalcinosis. There is even a physiological hyperechogenicity of the medullary pyramids seen in the neonates. This is usually towards the tip of the pyramids, like you see in this high resolution image. The same pattern of imaging can be seen in renal failure and dehydration with oliguria, or after prolonged use of diuretics like furosemide. And these are usually transient and go away after 7 to 10 days of life. But even in cases with oliguria with such manifestations, it can persist for some time after re-establishing a good urinary output. You just have to ensure that it goes away after some time. This appearance, however, can be similar to early nephrocalcinosis. We cannot completely distinguish between the two. So basically, you have to ensure that they are indeed transient, that there are no associated metabolic abnormalities, and correlate clinically to make sure that it is just a transient phenomenon of that particular newborn. There is also an entity called nephrocalcinosis of prematurity. The exact etiology of which is still hypothesis. A lot of hypotheses are there. In this nephrocalcinosis, it can even be unilateral, or if bilateral, it could be asymmetric, and all the renal pyramids need not be involved to the same degree. This also resolves over time, and by the time they are term equivalent, it just goes away. This is just a list of medullary nephrocalcinosis that everybody is familiar with, all the metabolic conditions, the metabolic derangements, etc. I'm not going to go into detail about metabolic medullary nephrocalcinosis. This is the typical appearance of medullary nephrocalcinosis, where you can see echogenic medullary pyramids. And because it's a systemic condition, both kidneys are affected almost symmetrically. This is how it looks on a high resolution ultrasound. Again, just want to stress that high resolution ultrasound is very, very important in neonatal imaging. Normal curvilinear ultrasound scans can appear normal, and only when you use focus ultrasound can you pick up subtle abnormalities. In nephrocalcinosis, just a few points that I want to stress upon is that even with such diffuse involvement of entire pyramids on both sides, renal function can still be preserved. And when you're following up these kids, the appearance on ultrasound can remain or it will be unchanged despite resolution of the cause of nephrocalcinosis. And medullary nephrocalcinosis can be seen associated with renal cysts in certain conditions like Barter's and distal RPA. And this is thought to be due to chronic hypokalemia. Now, increased parenchymal echogenicity, a very common thing that we all see in radiology reports or medicorenal disease or hyperechoic kidneys. What does this actually mean? This basically means that there is an increased presence of a material that reflects sound waves back. Thus, it appears more bright on our ultrasound images. It could be anything, a lot of things, like fibrous tissue, like in glomerulosclerosis or interstitial fibrosis, which increases the echoes, like it is seen in chronic renal diseases. Inflammatory infiltrates can cause increased echogenicity, like in acute interstitial nephritis or glomerulonephritis. Protein CAS can cause increased echoes, like you see in acute tubular nephrosis. Calcium or calcareous deficits or stones are, obviously, we all know it's very echogenic. So then it's not very specific. When you say there is increased echogenicity, it's not very, it may be any of these conditions. So increased echogenicity can occur in conditions that cause acute kidney injury or chronic renal disease and cannot be used reliably to distinguish between the two. Although in chronic renal diseases, usually the kidney sizes are smaller in most cases. But having said that, ultrasonography is still a useful tool in evaluation of AKI because it helps to exclude a lot of underlying chronic and congenital conditions. There is also a lot of talk about using Doppler and RI or resistive indices values to evaluate AKI and try to differentiate the causes of AKI. It has been said that RI is slightly high in obstruction and acute rejection in sepsis, whereas it remains normal in glomerular conditions. But again, that should be taken with a pinch of salt because RI values are age dependent, and at birth and in neonates and in preterms more so, the value can be higher and it normalizes by only around 4 to 5 years of age. Normalizes as in it becomes adult values only by 4 to 5 years of age. So a high RI reading in the neonatal period is not necessarily abnormal. So having talked about Doppler, we'll move on to another indication of Doppler in pediatrics, hypertension. The guidelines recommend that Doppler is a screening study for evaluation of possible renal artery stenosis in, and there are a couple of caveats here, normal weight children who are more than 8 years of age and who will cooperate with the procedure. So those are the caveats here. Again, like I said, RA is age dependent, so interpret that with caution. And the reliability of Doppler is closely related to the skill of the operator, the techniques that they use, how comfortable they are in working with the child in that age group, how cooperative the child is. And the child should be not obese because then your intonation differs, you're not able to get good images. So a lot of challenges are there to get good quality Doppler images. So it's not of much use, or it could be error prone in smaller kids. So what do we basically look for when you are evaluating pediatric hypertension? On Gray scale, we are looking at the morphology of the kidney, size of the kidney. Is there any scarring? Is there any hypoplasia or dysplasia? You're looking for any potential masses that can cause hypertension either in the kidneys or in the retroperitoneum or adrenal glands. On Doppler, you're looking at the waveforms and the velocity. So intrarenally, you're looking at a particular waveform. So if it is a slow peak, slowly rising peak intrarenally, you suspect that there might be some stenosis proximally. And proximally at the site of stenosis, there might be abnormally elevated peak systolic velocities. I'm not going to go into the details of that. The challenges, what is the challenges there? The challenge is, what if there is more than one renal artery? If there's an accessory renal artery, you are with difficulty insulating one renal artery and evaluating it. What if the stenosis is affecting the accessory renal artery, which you don't know exists? So there you're missing that. And suppose there is a multiple involvement or multiple focal involvements of intrarenal arteries are there, you can miss that. Or if there is a segmental involvement of one intrarenal branch, you can miss that, because how much can you sample? You can only sample a few areas. You cannot sample the entirety. So there are a lot of challenges. You can miss possibly you can miss findings, or you can interpret it wrongly also. But the key point is that if you find an abnormal waveform intrarenally, you sample more proximally, especially to look for stenosis in the main renal arteries or the suprarenal arteries. So having said all this, is it really useful in kids? Does it work? A lot of people have done a lot of studies over the years, and what they have said is that it is reasonably specific, but sensitivity is low. So what does that mean? It's not good enough, but still there is a value to it. It is still the appropriate initial test in children. It can direct further workups. It can tell you whether you need to go further and evaluate with angiography or CT, either CTMR or direct angiography, or it can provide alternative diagnosis like a mass or parenchymal abnormalities. And what do you do after you get a report from an ultrasound Doppler? If it is positive, which means that it's an abnormal flow pattern, then almost certainly you need to go out to look for, you want more definitive vascular imaging to look at either the main renal artery or the aorta, so CTMR or catheter angiography. What if it is negative? Then also you need to go on for other vascular imaging if your suspicion for an arterial or a vascular cause of hypertension or renal artery stenosis is high. So if the clinical suspicion is high and you have excluded all other causes of hypertension, with a negative Doppler, you still need to go on for vascular imaging. So just a few other uses of ultrasound in children. Infections, a common cause for referral to ultrasound, UTI. So in imaging, there's a lot of approaches for UTI, either top-down, bottom-up approaches, which I'm not going to talk about. What is the utility of ultrasound? Generally indicated in atypical or recurrent UTI or for children less than 6 months of age, but more practically, it is usually done in almost all cases of febrile first UTIs. Basically, what are we looking at? We're looking at morphological abnormalities. Is there any system dilatation? Is there any suggestion of a psychoureteric reflux? Is there any duplication? Is there any scarring to indicate that there has been prior infections or suggestion of chronic pyelonephritis? Is there any urinary tract dilatation? Is there any complication, like is there pyelonephritis at this time? Is there abscess or collection or pyonephrosis? And pyelonephritis, ultrasound is a very good tool to rule in pyelonephritis. Like if the clinical suspicion is strong for a neurosepsis or pyelonephritis, and renal size discrepancy might be the only thing that you see in ultrasound that can suggest pyelonephritis. So again, I stress upon the renal size measurement importance here. So the difference between the renal sizes on both sides. If one kidney looks a little bit bigger, or it's slightly out of your normal range or above the centile, then you definitely need to raise a suspicion that there might be pyelonephritis, provided there is a clinical suspicion in that aspect. So here in this imaging, you see this kidney which looks a little bit heterogeneous, especially in the upper fold, the loss of CMD. There's some system dilatation with some wall thickening. And on high resolution, you definitely see that heterogeneity of the parenchyma. And again, you can see the thickening of the urothelium. So this was a case of pyelonephritis. Other utility of ultrasounds, evaluation of hematuria. So a lot of causes for hematuria, you might not always be able to diagnose the cause on ultrasound, but a lot of things can be picked up, like masses, calculi. Is there any parenchymal abnormalities that makes you suspect a glomerulonephritis or interstitial cause of hematuria? In nephrotic syndrome, as a baseline study, you can evaluate the size of the kidney, the echogenicity, any complications such as renal vein thrombosis, presence of ascites or effusion. And also ultrasound and other imaging is useful in evaluation of syndromic nephrotic syndromes. And like I said before, ultrasound is a very good tool, not just for diagnosis, but also as a guidance for percutaneous interventions such as biopsies, abscess drainages, or vascular access for dialysis, etc. Thank you. That brings me to the end of the presentation.
Thank you, Dr. Shilpa, for that exhaustive review of ultrasound and making it a little bit understandable for us.
Thank you. I hope I have not made more confusions.
No, definitely not. I had a query to you, like in ARPKD, what is the earliest stage in which you can confidently pick up the cyst?
ARPKD.
Yes.
You can see the cyst even in the neonatal period. In most cases, it will be microcyst or just like ectasias. And in a couple of months' time, you can see definitive cyst. So, I mean, it's not that you cannot see cysts in the neonatal period at all. There are cases where you can see microcysts in the neonatal period itself. more commonly you see tubular ectasia kind of appearance, but in a couple of months time, you can confidently see actual like well-defined cysts,
Okay.
like 3 to 4 months of age.
Thank you. So next, we move on to the panel discussion. So the next panel discussion is on antenatal hydronephrosis. To moderate the panel discussion, we have two senior and eminent pediatricians with serious interest in pediatric nephrology. I invite Dr. Janaki Menon, Additional Professor and Head of Department of Pediatrics, Government Medical College, Thrissur, and Dr. Krishnan C., Additional Professor of Pediatrics, Government Medical College, Kozhikode, to moderate the session.
Thank you. Thank you, Radhika. Shall I start sharing?
Yes, ma'am.
We have a I hope it's well seen.
Yes, ma'am, it's well seen.
Yeah. Okay. So many thanks to the organizing team and IAP Cochin of this wonderful seminar today. The talks have been so good. I hope this panel too will do justice to the rest of the program. We have 3 experienced people who are panelists today, and certainly we will all learn a lot from them. Our participants today are Dr. Lenny Kumar Joseph, Dr. Manjusha, and Dr. Mohan Abraham, and they will be talking about management of antenatally detected hydronephrosis. Dr. Lenny Kumar is a pediatrician and a nephrologist who has extensive experience not just in pediatric nephrology but also in adult nephrology. He is a graduate of Cochin Medical College and has done a fellowship in nephrology, pediatric nephrology at St. John's and later in Singapore. And he works at Christian Fellowship Hospital, Odanchatram. Dr. Manjusha is a young and upcoming pediatric nephrologist who is a graduate of Trivandrum Medical College, who did her MD at Calicut Medical College and then her fellowship at CMC Velo, who also has some experience in UCLA in California. And she is now at Kottayam in Holy Cross Hospital. And the third and the senior most of all is Dr. Mohan Abraham, who is known to everybody out here. And he is the senior pediatric surgeon and a pediatric urologist at Amrita Institute of Medical Sciences, Kochi. He is an original alumnus of CMC Ludhiana and has so much experience in pediatric surgery and pediatric urology with a lot of innovative techniques to his credit. I think we will go on to the panel discussion, and Dr. Krishnan will kick off the program. Krishnan sir. Krishnan sir. Radhika.
Krishnan sir, can you hear us?
Sir, relay.
I'll try calling him.
No, Are our participants, are the participants here?
Yes, ma'am. Manjusha here.
Can you open your video, please?
Yeah, I have started my video.
Your video is open. Okay. Krishnan sir, you're muted. That's why. Krishnan sir, you're muted.
Now it's okay.
Right. Now it's okay.
Okay. So am I audible? I think I am audible.
Yes, you're audible.
Okay. So I take this opportunity to thank IAP and pediatric nephrology chapter for being participate in this event. Thank you, Dr. Radhika, and thank you, Dr. Janaki, for the words. So just a few words about the topic we are going to discuss. It's a very important topic because all of us are aware that antenatal ultrasound is being done regularly and almost it is universally done. As antenatal anomaly scan is being done regularly, almost universally, when all ladies, pregnant ladies undergo this procedure. So the chance of getting detected anomaly is almost between 5 and 6% of the scans could show some abnormalities. So it's very likely that the obstetricians, the pediatricians, neonatologists will come across this antenatally detected hydronephrosis or any other renal anomalies. So it's a very important topic for us. And for regarding the fetus or babies or the entire family, it's also very important problem because even though many of these antenatally detected hydronephrosis could resolve, it could be a transient hydronephrosis. It could be a forerunner of underlying serious conditions. The list of conditions all of us know, like sacroiliac reflux, PUJ obstruction, duplex kidney, or multicystic dysplastic kidney. There are a list of conditions. It could be just a anomaly, could be a forerunner of any of these. So once it is detected, they may need complicated procedures, regular follow-up surgeries may be needed, and counseling of the parents are very important to adhere to the procedures. Other thing is, if it is missed, that is also very important. Suppose it goes unnoticed, these babies are likely to go into a stage of chronic kidney disease, becoming dependent on the peritoneal dialysis, or later on they may require renal transplantation. So this is the topic we are going to discuss. So we are approaching this topic as a various case scenarios. So first of all, so I think we will go to the first case scenario. So this is a very common scenario, that is an antenatal ultrasound was done at the 20th week of gestation in a primary mother. And we showed an anteroposterior diameter of the renal pelvis on right side, a 5 millimeter size. It's a unilateral. And there was no other renal abnormalities according to the present ultrasound. And on seeing with this report, the obstetricians approached us. So Dr. Lenikumar, what is your advice on this scenario? And what is the expected course of this anomaly of this fetus you would predict? And could you please elaborate on the size of the APD and its significance? And another point we would like to clarify is how early an ultrasound during antenatal period can identify a renal hydronephrosis. So these are the points we would like to clarify, Dr. Lenikumar.
So am I audible?
Yes, sir. You are audible.
Okay. So what do we see here? We have an ultrasound at 20 weeks of gestation and 5 millimeter. So is that significant? And it is unilateral. These are the three things that we note here. So according to our ESTN guidelines and the subsequent guidelines, which came later, the antenatal ultrasound at 20 weeks showing 5 millimeter should be considered significant because it is more than the cutoff value of 4 mm. Now, what is the expected course of this anomaly? And what would I advise? So definitely I would advise them to repeat another ultrasound in the third trimester to look at the course and what is the expected course. The expected course of this anomaly, mostly it is likely to subside, but it is equally probable. It is very slightly probable that it might progress also. So the third trimester and postnatal ultrasounds, both are important in this. Now, what values that I told, and how early in gestation do you expect USG to detect hydronephrosis? So usually in the anomaly scan, what is called as the anomaly scan, which is done after, if it is done after 14 weeks, and generally it is around 16 to 18 weeks that is done. And that is where you are likely to detect a renal pelvis dilatation. Before that, you may see the renal tissue, maybe even as early as 9 or 10 weeks, and the echogenicity of the kidneys. But here we are looking at hydronephrosis, which is now one of the latest terminologies is urinary tract dilatation or UTD. And when it is in the third trimester, the significance, so values more than 7 mm and definitely more than 10 mm are considered severe.
Okay, thank you, Dr. Lenikumar. So this baby is having a unilateral hydronephrosis. Even if it is a unilateral and size is 4 mm, so this baby definitely need a third trimester repeat ultrasound and also a postnatal. So that is mandatory for this baby. And the size, if it is antenatal, first trimester, it is between 4 and 7. And if it is during the second trimester, if it is between 4 and 7 and 10 is you have to take it seriously. And if it is more than 10, it is more serious problem. Is it like that?
Yes.
Yes. So I think we will move on to the next case scenario. Dr. Janagi, please change it. Okay, so this is another case scenario we have. In this baby, in this fetus, that is, an ultrasound was done at the 20th week gestation again in a pregnant lady, and the ultrasound showed a bilateral, that is, both sides there are abnormalities, a 9 millimeter and 8 millimeter dilated renal pelvis detected, and here also there was no other renal abnormalities according to the present ultrasound. Dr. Manjusha, what is your opinion on this scenario? This baby with this report is in front of us, and what is the expected outcome for this fetus likely? And could you please elaborate on the what usual? How will you interpret the diameters of a particular ultrasound report with its outcome? So these are the 3 areas, points you would like to clarify.
Am I audible?
Yes, Manjusha.
Thank you, sir. So as you have already mentioned, sir, and in antenatal ultrasound scans, we grade antenatal hydronephrosis based on the renal pelvis.
Manjusha, volume, is it okay? Volume? Ratika, is it volume okay?
Sir, am I not audible?
No,
yes,
okay.
yes, you're audible. You're audible.
Okay.
Go ahead.
Yes.
So as in the antenatal ultrasound scans, we grade the severity of hydronephrosis, as you have already mentioned, based on the renal pelvis anteroposterior diameter. So in this scan, based on the grading of the antenatal hydronephrosis, this comes to a moderate hydronephrosis in the second trimester. And it is bilateral. So bilateral hydronephrosis has a greater chances of progression in the further periods of gestation. So definitely this child needs more close follow-up and repeat ultrasound scan to be done. So, and bilateral hydronephrosis have a lesser chance of spontaneous resolution during the in the pregnancy or in the postnatal period. That means there's a greater chance of having an underlying pathology which is causing this hydronephrosis. So definitely we need to follow up this case with another ultrasound scan. We usually, based on the severity of the hydronephrosis, we follow up at 4 to 6 weeks. That is the frequency we advised, but it can be done earlier if there are more anomalies like lower urinary tract obstruction, features of lower urinary tract obstruction. So this child definitely needs a follow-up ultrasound scan. So does the APD predict the outcome? So severity of renal pelvis dilatation has importance in predicting the prognosis, because more severe the antenatal hydronephrosis, there is less chances that it can undergo spontaneous resolution, and there is higher chance of postnatal pathology underlying, and also chances of more urinary tract infections in the postnatal period. So so definitely, and also if there is a progression in the anteroposterior diameter in the follow-up scans, that is all the more important of an underlying pathology.
Okay. Yes. So this is the classification regarding the risk stratification of the hydronephrosis depending upon its sizes. Okay. So in this baby, we had since baby is having bilateral hydronephrosis and size is more than the previous baby. So this baby need more close follow-up, more frequent ultrasound examination during the remaining pregnancy period, and also a postnatal ultrasound is important. And we would also ask the ultrasonologist for looking for other abnormalities during the subsequent ultrasound examination also. Is it like that?
Yes. Yes, sir. Yes.
Okay. Okay. So that is a point in this case. Okay. Shall we move to the next scenario, Janaki? Okay, sir. Dr. Mohan Abraham, this is another scenario. This is a baby who underwent some ultrasound examination at the second trimester, which detected some abnormality like dilatation of the APD, and a follow-up ultrasound was done at 34 weeks. And during the follow-up ultrasound examination, the initial hydronephrosis was persisting. In addition, the sonologist also reported a bladder wall thickening. The bladder was dilated, and there was oligoamnios with a amniotic fluid volume of only 300 ml. So, Dr. Mohan Abraham, what's your comment on this case scenario with this report at this level?
I think this is a late presentation, and we have missed the opportunity to intervene in this, because most probably this is a posturethral valve which has produced the hydronephrosis, and there is already significant kidney damage, because 300 ml at this gestational age, there should be about 1000 ml of amniotic fluid, but it's about 300. So that is definitely a poor prognosis. And at this point of time, we cannot intervene. It's too late for a fetoscopic valve ablation, and it's also too late for a vesicoamniotic shunt, because vesicoamniotic shunt at this time doesn't improve the renal outcome. It only improves the pulmonary outcome, if at all it improves. So the best thing at this point to do is to give steroids for lung maturity, and then go for an early delivery, because 34 weeks, these children or babies are salvageable. So go for an early delivery at this point, and tell the parents that we need to have a very close follow-up. I have had babies who had very severe oligohydramnios, almost anhydramnios, but when they are born, they tend to do well. Definitely in course of time, maybe by puberty, they may have some renal compromise, but they can have an outcome. But on the whole, majority of them, we have to tell the parents that this baby will need very close follow-up with monitoring of blood pressure, urine, RFTs, and other things, and growth parameters, etc. There's a possibility, there's a high possibility we may go into a renal transplant at some point of time.
Okay, so you told that we missed that early detection. So this baby was initially detected, follow-up was run only at 34 weeks.
Yeah.
So how early we would advise? Suppose following detection, suppose we detect an anomaly at 20 weeks. how frequently we would go for a repeated ultrasound?
If you dictate 20 weeks, depending on your findings, if the kidney renal tracts are dilated, and if the bladder emptying is not seen, because every fetus empties a bladder in about 60 to 80 minutes. So if the ultrasonologist just views the bladder emptying and find that it is not emptying, that means we have a red flag over there that there may be a PV. In which case, early in 20 weeks onwards, we monitor them every 2 weeks by a follow-up ultrasound.
Okay.
And you monitor the renal outcome. You look for parenchymal changes like formation of cyst, increase echogenicity, if that is there, or increase in the diameters of the APD, or if there is oncoming oligohydramnios. Because we can intervene fetoscopically, we can ablate this valve only till about 24 weeks. After that, the angulation between the bladder and the urethra becomes so severe that we cannot introduce a fetoscope into the urethra to ablate the valve. So that your ablation with fetoscopic intervention, that gives that saves the kidney as well as the lung because of the increased amniotic fluid. But after this, we can do a vesicomniotic shunt. But shunt will definitely improve the amniotic fluid volume and the lung outcome. But it doesn't. There's been studies have shown that it does not improve the renal outcome. So that's why I said it's a little too late to do anything now. Because 34 weeks, that baby is salvageable. Baby will survive. So give steroids for pulmonary maturity, and then take off for early delivery.
Okay, so thank you, sir. So the lesson is once you detect the abnormality, we need more frequent follow-up ultrasound examination, and the presence of oligomenosis is a obvious sign which suggests pulmonary hypoplasia, and a bladder distension suggests a severe obstruction like PUV or other obstructive uropathy.
That's right.
So yes. So with that, we can move to the next case scenario.
Just sharing some images of fetal hydronephrosis and dilated urinary tract.
Okay. Yes.
This is showing the dilated posterior urethra.
This is a keyhole sign, I presume.
This is the keyhole sign.
Keyhole sign with the distended bladder with the dilated posterior urethra. Previously,
and this is similar to your patient who had less than 300 ml of amniotic fluid.
Okay, that's just a pulmonary hypoplasia.
Suggesting pulmonary hypoplasia, Porter syndrome.
Okay, so the key is one should be looking for all the details in the ultrasound so that you can it will give a lot of information regarding the outcome and the underlying issues in that particular fetus. I think we will go to the next case scenario. So here in a fetus with a bilateral antenatal hydronephrosis which was detected at 28 weeks of gestation, a follow-up scan was done again. And which showed a persistence of hydronephrosis. In addition to that, the sonologist reported an additional finding in the form of a shortened humerus, which was seen bilaterally. So, Dr. Manjusha, how would you interpret this new finding? What is the importance of new finding in this present ultrasound compared to the previous finding? And please elaborate on the various soft signs in ultrasound scan reports, which may suggest need for genetic counseling, genetic testing, referral to other centers, etc.
Soft signs in ultrasound are subtle abnormalities that we see in ultrasound, even in normal pregnancies, which are of not much importance in isolation because majority of it settles by term gestation. But when present along with other abnormalities, it's of importance. And isolated antenatal hydronephrosis itself is not much associated with any chromosomal problems, aneuploidies, but when present with other major structural problems, any other system involved like the heart or the CNS, if there are major structural problems along with hydronephrosis or presence of soft signs, like as mentioned here, a short humerus or a short femur or echogenic bowel or echogenic foci in the heart or a nuchal translucency or a ventriculomegaly, all these along with the presence of antenatal hydronephrosis. So that is of importance because then we need to think of any underlying chromosomal problems. So presence of hydronephrosis along with any other major system involvement, major structural anomalies, any one structural anomaly, or along with the presence of one or more soft signs, that is an indication for evaluation of any underlying chromosomal pathology, underlying aneuploidy. So that needs that may need prenatal counseling.
Echo from it. Okay.
Hello.
Settled.
Hello.
Manjusha, continue.
Yeah, so that may need evaluation prenatally, which will need prenatal genetic counseling, other evaluation with amniotic fluid, amniocentesis, for looking for chromosomal abnormalities and to decide on the further course of pregnancy. But in this case, I think it's already 28 weeks. So, so anyway, it will give a prognosis in the whole sense. So this child will need evaluation, like if further like more structure, more soft signs are there, or any other structural abnormalities also detected along with this.
Okay, Manjusha. So that means the message for this case is that we have to, in addition to the renal abnormalities, other findings also one would look for. Like if there's any other soft signs, we may have to think of referring a center where genetic counseling is available, genetic testing is available.
Yes.
We have to educate the parents for the need for the possibility they may probably require genetic counseling and the genetic testing.
Yes.
So so that identifying or promptly interpreting these soft signs with this fetus is very important.
Yes. Yes, sir.
Okay. Sir Mohan Abraham, sir, here this is related to the previous case scenario we have discussed with the baby with hydronephrosis, with bladder distension, thickness of the bladder wall, and the oligomneus. Here, so could you please discuss the indication for surgical intervention during antenatal period itself in an identified case of antenatal hydronephrosis, and what are the modalities which you might have tried in the various cases, and what is the feasibility and outcome of these procedures in the fetus and babies in our population, with regard to our population, sir?
No,
please,
for
yes.
So antenatal hydronephrosis, if it is, I mean, mainly there are three reasons. One is a pelviureteric junction block, where there is a block between the pelvis and the ureter, and it is always partial. It is never a complete obstruction. Second possibility is at the VUJ, a vesicular-ureteric junction. Again, it is a partial block and not a full block. Now, it can also be because, as we discussed earlier, because of PUV. Now, can you hear me still?
Yes, sir. Yes, sir.
Yeah.
Please continue.
So these are the three. Now, for the PUJ, even if it is unilateral, whatever be the distension is, you are not entitled, or it is not scientific to intervene and put in a shunt in the pelvis. The reason being, in PUJ, what happens is because of the increased obstruction on one side, the other side goes into sort of hibernation. So because of that, that kidney remains protected. So there is not that much of damage as we expect in a post-urethral valve. So that is why we don't recommend an antenatal intervention in hydronephrosis, even if it is bilateral, because both those kidneys will be functioning. Now, VUJ also, it is the same etiology. It's a partial block. It is because of the non-distensibility of the VUJ, or something like a a spasm at the VUJ. So over there also, there is no indication for fetal intervention unless and until, as Dr. Shilpa was saying, there's a uretrocele associated with it. Because if there's a uretrocele, then we can, go with a needle and puncture the uretrocele so the kidney can be relieved. Apart from that, there is no indication. The only indication is when there is a reflex again. There is no indication for a fetal intervention in reflex. The only indication is where there is a post-urethral valve. As I discussed earlier, we had to do it before 24 weeks. That will protect both the kidneys and the lung. After 24 weeks, we can put in a shunt. It will improve only the lung function. Kidneys will remain, bad and unaffected. Unaffected means not without any improvement. And then go for an early delivery. So these are the options that we have with us.
Okay. So is there an option for a fetal ablation like that?
Scientifically not. I mean, ethically not. Okay. The reason because these see in fetal surgery, we have to classify into lethal and non-lethal conditions. If it's a lethal condition, you are justified in termination. But if in a non-lethal condition, ethically, you are not justified in termination. Now, this is a very gray area. Now, you tell one of our poor patients in India that your baby is having a post-urethral valve and is having oligohydramnios, is going to have a very bad kidney, chronic renal failure, multiple admission, multiple surgeries, and even eventually renal transplant. I'm not sure from that point of view, to say that you should not terminate is morally right or not.
Okay.
Because that's is an ethical problem. I mean, I don't know, but scientifically, we are not allowed to advise termination in these cases.
Okay, sir. What is your comment on any trans-abdominal amnio infusion which may reduce the orgamnios, may protect the lung? Is there any possibility?
Yeah, definitely. We have done that. We have given amnio infusion. That will improve again the lung function. It's not going to improve the kidney function.
Okay, suppose there is a severe orgamnios, we can try serial amnio infusion. Okay.
Yeah, that's right.
Okay. Okay. I think, Janaki, can we move to the next scenario? Okay, so this is a very common scenario. So for a pediatrician, Dr. Lenikumar, sir, could you please elaborate on that? Because we have during a postnatal rounds, by a pediatrician or a neonatologist detected during screening of the antenatal details, found to have the baby had detected to have some antenatal hydronephrosis. The baby is born now. So now what is the treatment protocol you would suggest? And with regard to the examination of the baby at present, how will they monitor in the later hours? And what are the investigations? At what time would you suggest? Please, could you please discuss these few points?
First of all, I would like to see the antenatal scan, the scan report, antenatal scan report, and also the sex of the baby, whether it is unilateral or bilateral, how severe is the hydronephrosis. Based on this, the timing of the subsequent ultrasound, postnatal ultrasound will be decided. Generally, the scenario where majority of them are having mild hydronephrosis or unilateral hydronephrosis, we would advise the ultrasound after 48 hours, usually towards the end of the first week. I usually do it at 5 to 7 days. So many a time now there is a tendency of discharging these babies early from the postnatal ward. If there is a chance of missing them, and if it is a moderate hydronephrosis also, I probably may ask early. But generally the safer thing is to advise the parents bring the baby for an ultrasound on 5th day, 6th day, or 7th day. Take an appointment and bring it. That postnatal ultrasound definitely is needed, whether it is unilateral, bilateral. So if you have the likelihood of lower tract obstruction, especially in a male baby, that is bilateral hydronephrosis, moderate to severe hydronephrosis, or if there is renal parenchymal involvement. If there is a likelihood that that is a baby who is going to require some intervention or further evaluation, that baby will have to be evaluated early as far as ultrasound is concerned. But before we go for the ultrasound, I would like to know the creatinine as well as the urine analysis status of the baby. Creatinine, as we know, the first 48 hours, the maternal value may be reflected in the baby. So again, on the 3rd day, the creatinine 3rd or 4th day, it will have to be done. And also a urinalysis, especially urine albumin, then microscopy to see, because what we are worried about when we are seeing bilateral or unilateral significant hydronephrosis is that whether there is a likelihood that the baby will develop infection. So that is where we are. Am I audible?
Yes, you are.
Yes,
Yes,
sir.
go ahead.
Please continue.
Okay. That is where we are more worried. So if it is a mild hydronephrosis, we can even delay the ultrasound to a later date also. Even if that first week ultrasound is normal, we have to do one more at 1 to 3 months of age. And if you do it in the first 48 hours, there is a likelihood that you may miss some significant hydronephrosis, which is likely to progress. Now, supposing you have a scenario where there is a hydronephrosis, which is there antenatal, postnatally also it is there, it has not progressed, repeat at 1 month, it has not still progressed, but it is still there. You can do it at 3 to 6 monthly intervals. And also advise the parents on early detection of urinary infection, whatever be the cause of the hydronephrosis. So any febrile, you have to follow up the weight of the child. If the weight gain is not adequate, or if the child is having any non-specific symptoms of unwellness, like vomiting, feed intolerance, or if the child is having any febrile illness or any urinary symptoms, definitely a urine analysis has to be done, especially a urine microscopy with or without a culture. So in my practice, I have found that this advice helps rather than doing a blanket of investigations initially or putting them on antibiotic prophylaxis. Now, when will I put them on antibiotic prophylaxis? If I deem that this is a child who is likely to require an MCU, so such children will need antibiotic prophylaxis till you can do that MCU procedure. The caveat is that the MCU procedure itself can trigger an infection, and I have seen babies like that. But still, for the general pediatrician, if you have a severe hydronephrosis, bilateral, with significant post-void residue, that is another thing which I forgot. When you ask for the ultrasound, you should ask the radiologist to do it on a full bladder and post-void. It is not very easy in a neonate. So you may have to wait. When was the previous voiding? And after that, even a simple thing, in a baby who has a bilateral or significant hydronephrosis, when did the child pass urine? So I usually prefer to observe the baby in the level 1 nursery or in the ward where we can observe the baby for the urine output and volume. So these are the clinical points. The rest of it will depend on the severity of the condition and what we find, whether there is abnormal urinalysis or abnormal creatinine. Thank you.
Yeah, one thing can I add is that if you're suspecting a posturethral valve because of the distended bladder, it may be wise to get an ultrasound done before you put the catheter, because we advise them to put a catheter as soon as they are born. So once you put the catheter, the whole upper tract is decompressed, and your ultrasonologist may report as a mild hydronephrosis or maybe nothing. So if you are suspecting PUV, before, if possible, before putting in a catheter, get an ultrasound done, and then later on you can repeat as doctor said later on at some time.
Okay, so that means if the obstruction, if you suspect a more severe obstruction like a diameter is more, or if there's a bladder distension, so we have to call the pediatric surgeon early. Within 24 hours, within 48 hours, we have to do a pediatric surgeon consultation. Pediatric surgeon should see the case and categorize and do accordingly. That is the one thing. And all these babies detected antenatally should be evaluated postnatally. Probably best way is to admit them before don't send them before completing the full evaluation. That is the other message I think we have to take. Okay, I think Janaki, is it over?
Yeah, the next
Okay.
question. It's to Dr. Manjusha.
Before that, I would like to, before handing over the mic to Janaki, I would like to thank all the panelists who were excellent, gave excellent comments and interpretation of the case scenarios. Thank you so much. So please continue.
The next question is to Dr. Manjusha. Association of renal dysplasia is an important determinant of outcome of antenatal hydronephrosis. So what are the USG findings which suggest an associated renal dysplasia and antenatal hydronephrosis?
So, in any child with antenatal hydronephrosis, we should look for features of renal dysplasia also, because it has important bearings on the prognosis. So on ultrasound, what are the features of renal dysplasia? So we have to look at the renal parenchyma, increased parenchymal echogenicity, loss of corticomedullary differentiation, presence of cortical cysts, and usually we expect a bigger kidneys on the side where there is obstruction, but on the contrary, if you see a smaller kidney on that side, it is also more a feature of underlying associated renal dysplasia.
Right. So antenatal hydronephrosis could turn out to be either a cystic dysplastic kidney or it could be a PUJ anomaly, right?
Yes.
We often see this, and the management of the two is so different. So how do you differentiate?
So it may be actually difficult to differentiate between the two antenatally, but definitely postnatally it will be more easy. So cystic dysplastic kidneys, we can see cysts, but it will be more like they will not be intercommunicating. They will not be communicating with the pelvis, and the parenchyma. Parenchyma will be hyperechoic, and that is the main difference with pelvic junction obstruction, where you can see the pelvis communicating with the cystic dilatation of the calyces. There is communication between the cyst and the pelvis, but in cystic dysplastic kidneys, usually we see the cysts are non-communicating with the pelvis, and the parenchymal echogenicity will be increased. So that's how we usually distinguish.
And probably on follow-up, the size of the dysplastic kidney
will come down,
gets smaller, and the other one gets bigger.
Yes.
Right.
Yes.
Right. Thank you. Yeah. So again, I just thought I'd share a few slides of multicystic dysplastic kidney, but then we have already had a very nice exhaustive talk by the radiologist, and these are probably redundant. Dr. Mohan Abraham, sir, when would you advise an MCU in a baby with antenatal hydronephrosis? And is it indicated if it is unilateral hydronephrosis?
Well, good question. As earlier discussed, if the hydronephrosis is mild, maybe we can wait. As you said, we do a MCU maybe about 1 month of age or something. But then this has a lot of risks associated with it. Now the baby is coming from, say, Katapana or one of the higher ranges where they cannot come back after 1 month, or they may not come back after 1 month. In that case, it is better to do an MCU before the baby is discharged, even if it is unilateral. Because many times it has happened that we advise them to come back after 1 month for an MCU or a repeat ultrasound. They never come back. Then they come back with severe urinary tract infection, pyelonephritis. So it depends on where the baby is. The baby is near you, they are educated enough to come back to you. Then maybe we can wait for a month, repeat an ultrasound and see what is the situation like, and then decide on the MCU. But MCU, I think in our setup is mandatory. There are centers in the West to advise. There are more than two. That's a latest American Neurology Association's guidelines. Only if they get 2 episodes of infection. Earlier, it was 1 episode of infection. They had changed it now to 2 episodes of infection. But in our country, I think it is better if they get 1 episode of infection, go ahead with an MCU. And if they are born in your nursery, get an MCU before the baby discharge. You will be much safer, at least legally.
Oh, so very early.
Yeah, agreed. But what if they come back? It has happened to be with me. One patient who came back later on, and we found that there's a reflux and the kidney was dysplasia. Actually, it's a congenital dysplasia, but the kidney had reported about 35%, in the DMSS scan. And the father said, "See, look, we came to you early. This was antenatally dictated. You did not do anything. That's why the kidney is damaged." Now, there's nothing we can say to it. And in our court, it's not doctors who are sitting as judges.
Right. Right.
So can I add something?
Yeah, of course.
Yeah, please do. Please do.
So, MCU, there are 2, like when you want to look at a distal obstruction and when you want to exclude a reflex. Now, after reflex, if it is a severe reflex, how early would you advise surgery, sir? Otherwise, it is mostly a question of antibiotic prophylaxis only, which our Indian Society of Pediatric Nephrology anyway advises for 1 year for all sorts of.
Yeah, see, all these studies, even Cochrane base, if you go, all the studies they have reviewed, they never took into account the bladder function. Well, most of these patients, the underlying problem is a bladder function. There's a high pressure bladder or there is a dysfunctional voiding which produces high pressure. And that is what is actually producing mucosal ischemia, colonization of the bacteria and infection. So these studies have not taken that into account. That is why if you go to Cochrane review, they will say that even if you do surgery, the number of infections remain the same. So then why do surgery? Because there's no difference between antibiotic prophylaxis and surgery as far as infections are concerned, because we have not undertaken to correct the basic abnormality. So that's the reason. So we have to take all this with a pinch of salt. If it's a high-grade reflex, the criteria to go about is not the age, because when I was doing MCH, I was also told you wait for 1 year of age, because when the child start walking, the gravity will help to, to reduce the reflex. But now you have to go by DMSA scan. You do a DMSA at about 1 or 2 months of age, and then follow up with the DMSA. I have followed up, reflux for 3 years and 4 years. As long as the DMSA does not show any increase in scars, then you are justified. But if DMSA shows an increase in scar, then you have to intervene. Because whatever prophylaxis you give, either the parents is not recognizing their child is having an infection or is an asymptomatic infection. The kidney is getting damaged. That's the bottom line. So if you can do repeated DMSA, we do it every 6 months. Every 6 months, you repeat a DMSA, see whether there is an increase in the scars. If there is an increase in the scars, then you have to, or you should have somebody like Dr. Silpa, who is a very good, pediatric ultrasoundologist who can detect scars on ultrasound. In many of the foreign countries, that's what they do. You do a nice ultrasound with a good machine, you can detect even scars and deformities on the renal cortex on ultrasound. That's the best thing to do because it doesn't give any radiation, it's cheap. DMSA also does not give much of radiation, but what was said and done, theoretically it does.
And it's not cheap.
And it's not cheap.
Okay. Just again, sharing just for the interest. An ultrasound scan showing the keyhole sign and the spinning top on the MCU. Dr. Lenny, the next question is to you. And antenatal hydronephro is an important fetal anomaly. I think we said this before, right? We got Dr. Mohan Abraham's take on this. Is there a role for termination of pregnancy? What do you feel?
As Dr. Mohan had already
spoken about it.
Yeah. And our Indian Society of Pediatric Nephrology guidelines in 2013 had addressed this issue very clearly. The recommendation 4 says that there is no role for termination of pregnancy. Here we are not speaking about the child with bilateral renal agenesis or dysplasia and water facies and incompatible with life and all that. This is antenatally detected hydronephrosis. So here the worst case scenario probably that you get is a PU valve, a very bad PU valve. But even though PU valve is a bad disease to have, scientifically it is treatable, and even ethically also, most of the time the detection will be past the period for legal termination. Even otherwise, we can never say. We heard that Dr. Mohan saying, no, that 34-week child. So you can deliver that child. Many of those children have done well. So in a case of PUV or hydronephrosis, you can never be sure what will be the postnatal course. Unlike the open and shut case of bilateral renal agenesis, pulmonary hypoplasia and all that. I don't think there is a role for termination of pregnancy. And that is our Indian recommendation also.
Yeah, thank you, because this is a question which comes up very often. And usually it is the obstetrician who sends the patient to us, the mother to us, and then we are stuck with the onus of answering them. So this is for comments from all of the panelists. What are the errors that you have come across in your practice with respect to follow-up investigation and referral of babies with antenatal hydronephrosis? Dr. Lenny, can you start? 1 or 2 errors.
Yeah. One thing is the over investigation, like Mohan sir may be able to do a perfect MCU in a small child, maybe less than 1 month old also.
Right.
But in an average setup, performing an MCU is not an easy task. And even in a very big tertiary institute, I had seen a child who was investigated with an MCU very early in life, in the neonatal period, and told that it was normal. And later, when the child was around 1 year of age, came with severe bilateral pyelonephritis, and the child was in frank renal failure. We had to initiate the child on dialysis. And because the patient had a bad experience, that was missed in pediatric surgery, second time they straight away went to adult urology.
Oh.
That was one of the fallacies of doing an MCU and judging it as normal in a small child, especially a neonate. We have to be aware of. The same can be there with radionuclide scans also, because the maturation of renal function, that factor you have to consider. So the other aspect is, I have seen children who have developed non-obstructed, non-reflexing megaureters, but following the catheterization and intervention for the MCU child who did not have a frank UTI before, coming with almost urosepsis. So don't attempt it if your setup is not fully equipped to that. You should understand your limitations. So that I will leave it to the other panelists.
Yeah, Manjusha, what do you want to say about this?
Yes, ma'am. So I think regarding MCU, sir has already told. The faults that I have seen during follow-up is that an early ultrasound which is being done, which usually happens before the 3rd day, and I don't know whether the parents take that it is normal, so no need of further follow-ups, or somebody else telling them. So that such children, like such kids, coming later with significant uropathology. So that is something which I would like to tell, that when you do an ultrasound, especially when there are no features of any significant lower unit tract obstruction, that the postnatal ultrasound be delayed after 3 days, and one ultrasound after in the postnatal period it should be followed by one more ultrasound later to make sure that there are no major pathologies underlying. So that is what I have seen. The too early an ultrasound scan in the postnatal period can miss hydronephrosis. And the problem is that it gives a false reassurance to the parents. So despite sometimes doctors advising them,
so
for
they
an
do not come
ultrasound
at all for follow-up.
Yeah, that is what, and later coming back with some complications. That is what I have more frequently seen.
Dr. Mohan sir, what's your
yeah, this is regarding the MCU. We had bad experience with MCU in the when we started the unit in the beginning, because the bladder volume of the baby, especially when they are PUV, they may be very contracted small bladder, or they may be big bladder. So what happens is, normally the radiologist, not in Amrita now, but earlier on, they inject dye with a syringe into this bladder. And when they think the bladder is full, then they take the films. And when the child is not passing the urine, they will give suprapubic compression, make them pass urine and take a film. And this is a normal practice. Now, the problem is, we don't know what the bladder volume. We cannot go by the age of the patient or the formula of, weight into 7 or whatever. But what the American Radiology Association, what they recommend at the moment is to fill the bladder in a drip way from 1 meter height. So 1 meter height, you hang the tube, hang the bottle with the dye, and put in an IV set and connect it to the catheter. So the reason is 1 meter is as a maximum pressure, avoiding pressure a normal male baby can have. So that is physiological. And secondly, since the bladder is fully full, it may take 30 ml, it may take 60 ml, but once it is full, you remove the catheter, bladder will contract reflexly like a normal voiding, and you'll be able to get a good stream. This way is very unlikely that we had bladder ruptures following MCU. That is why we insisted on this, and now our radiologists are following that protocol. Now, another thing is in small babies, less than 1 month, we catheterize ourselves. We don't send it to radiology. Because in a center like ours, where there are so many trainees, first year radiology, PGs and all, the sterility cannot be guaranteed. So we call them to our OPD. One of our senior people catheterize the baby and then send them to the radiology with the catheter, tell them to install the dye and just remove the catheter, send the baby back, don't recatheterize. So that way we can prevent the infection to some extent. And we also give them prophylaxis. We give them something like cefixime a day, starting a day before the surgery, BD dose, and to lasting a day after MCU, not surgery, after MCU. So day 1 on the day of MCU, and then 1 day after MCU. So that also, take care of the infection to an extent. But
yes. So we need to consider that MCU is a serious thing and should be treated like a surgical procedure done under aseptic precautions under the proper guidelines with antibiotic prophylaxis.
Because your findings of your MCU is going to determine our modus operandi or our further course of action.
Right.
So if you have a wrong MCU, we will, as Dr. Manjusha said, we send the baby home and then later on come back with renal failure.
Right.
Thank you.
Thank you, sir. Dr. Lenny, one more question to you. Antenatal screening for renal anomalies is so widespread now and so easily available. And over your so many years of practice, you've been working in adult nephrology with adult renal patients also. Do you feel this has made an impact on child health and the prevalence of chronic kidney disease?
Sadly, it so far doesn't seem to have, because what we see is this only constitute a very, very small part of. I do have patients, young patients, especially males, whose renal disease is obstructive. But how much difference it would have made to them if an antenatal ultrasound had been done, maybe it would have added a few more years. But there is really not much literature. Actually, I tried searching also. So it is so far the impact of that, because it may have the opposite impact also, like causing unnecessary anxiety in parents. The more severe ones, missing UTIs, recurrent urinary infections, then not properly evaluating a UTI at the point it occurs. These are other things, and as well as the bad follow-up. So having a rapport with the family and keeping them under regular follow-up, we can push them on for a few more years. We can delay the transplantation. That is the maximum we can expect in most cases of bad PUVs also anyway. So the impact on child health is definitely it might have an impact, but on the prevalence of chronic kidney disease, it is doubtful. Although many of our Indian society recommendations for this aggressive MCU is based on a presumption that even antenatal ultrasound may not be available in many places, may not have been done, and a large proportion of childhood or adolescent or young adult CKDs are from obstructive causes. No, as of now, at least in the south, what we see is they are mainly glomerular diseases. The proportion of obstructive is quite small, and whether that can be improved by an aggressive monitoring and management is doubtful.
So it may be possible that the obstructive features tend to become more severe infection in the in the childhood period, so they tend to get weaned off at that point. So by the time they become adult, those who come to you, they may be having more of glomerular disease. So it may be just a screening process, because if you have a PUV, if you have a obstructive megaureter or a hydronephrosis, they will become symptomatic much before adulthood. So they will be picked up before that.
Right. Anyway, the idea of antenatal screening is so that it will have an impact on child health and that we will reduce the prevalence of chronic kidney disease. And probably time will tell, and more studies and more interventions, early interventions. So with this, we come to the end of this interesting panel discussion. And I thank all the panelists for their input, which has come from so much of hard work and so much of experience. And on this note, I think this was the theme of World Kidney Day in 2016, act early to prevent it. I think that's very apt for this discussion that we've just had. So thank you very much. Thank you, everybody.
Thank you.
Thank you, ma'am.
Thank you, Janaki Madam, Krishnan sir, Mohan sir, Dr. Manjusha and Leni sir for this wonderful panel discussion. We, I think, covered almost everything starting from antenatal to postnatal evaluation. We are running a bit behind time. So let's straight away go to the next talk, which is on renal tubular disorders, which is another gray area for practicing pediatricians. To talk on this, we have none other than Dr. Susan Udup, Professor and Head Department of Pediatric Nephrology at City Hospital, Trivandrum, who you could say is one of the torchbearers of pediatric nephrology in the whole country. Over to you, ma'am.
Thank you, Radhika, for that wonderful introduction, and let me thank IAP Cochin for hosting this Nephro Kid 2021. And can you see my slides?
Yes.
Okay, so after a long morning program, actually we are almost at noon, and this is a topic that may be considered as little heavy for people to understand, and I hope that I will be able to do justice to the topic and at the same time not bore you too much. So renal tubular disorders is a problem that is important in the pediatric age group, because the tubular disorders will
Madam, the slides are not in presentation mode.
Okay. So these in the pediatric age group, the children will be presenting with multiple issues, and timely detection of these issues is important in getting a good outcome for these children. So in the next 30 minutes or so, I will be discussing how renal tubular disorders are creating trouble in the pediatric age group. Renal tubule can be actually considered as nature's wonder, because as we all know, the glomerular filtration that is happening in the Bowman's cup, and this ultrafiltrate is moving through the entire tubules
that is proximal tubule, which is having a convoluted and a straight segment, then the loop of Henle, then distal tubule, and the collecting duct. By the time it reaches the renal pelvis, only 1 to 2% of the full ultrafiltrate is actually coming out here, because almost 99% of it is getting reabsorbed. So this is actually the wonderful thing that tubule is doing in maintaining the water balance. And not only this, the kidney tubules are concerned with handling the acid and the base, so that our pH remains around 3.4, 7.4, and the electrolyte balance, sodium, potassium, chloride, calcium, magnesium, all these lights are maintained in the normal proportion, as well as our blood pressure is maintained. And we have to understand that bulk transport is happening in the proximal tubule, while the fine tuning is happening in the distal tubule. So this is William Harvey, who said that actually the nature is actually wonderful in its functioning, because from one cell we are all turning over to an adult human being with all the organs functioning well and remaining healthy. And sometimes the nature also will go wrong. And the secret mysteries of nature's wonderful things are displayed when actually such mistakes happen. And that is what is happening in renal tubular disorders also. But at the same time, we have to understand that all we know is still infinitely less than all that remains to be known. So let us see a few babies who were having some tubular problem, and that was creating an impact on their health. This little baby, the third child of non-consanguineous marriage, presented at 6 months of age because he was not growing well. He was failing to thrive, and he was 3 kg, normal term baby at birth. There was no polyhydramnios, but the mother noticed that the baby was irritable most of the time with poor feeding and frequently used to pass urine. And baby was admitted at 6 months, and at that time, this birth weight of 3 kg child was by now only 3.8 kg. He was dehydrated, his blood pressure was on the lower side, and there is history of a baby death in the family, who was their first child, who was female baby, who also had failure to thrive, and the baby died at 4 months. The second child was normal. So this baby is having a lot of urine that is passed, that is polyuria, and there is failure to thrive. So do we have to blame the renal tubules for his problem? So the features that will actually point to a renal tubular disorder are, one of them is failure to thrive and polyuria. Then there could be salt wasting, there could be refractory rickets, there will be renal stone disease that is there in some babies, sonologically nephrocalcinosis may be there, and some children may be presenting with unexplained and resistant hypertension. And when we assess the metabolic parameters, you may get the normal anion gap metabolic acidosis or metabolic alkalosis, sodium imbalance, potassium imbalance, then calcium that is lost in urine, or phosphate that is lost in urine. So let us look at what is happening to our baby who is having failure to thrive and polyuria. His hemogram was mostly normal. His urinalysis and urine culture were also normal. The glomerular filtration calculated was normal, but his electrolytes were actually abnormal. He was having sodium that was on the lower side, hypokalemia, metabolic acidosis, hyperchloremia, and his pH was also on the lower side. At the same time, his urine pH was high, that is 6. And the 24-hour urine calcium estimated was more than 4 milligram per kilogram per day, that is signifying hypercalciuria. And an ultrasound scan abdomen showed medullary nephrocalcinosis. So this baby is having metabolic acidosis, hypokalemia, and failure to thrive. So this baby is having a tubular disorder that is causing an abnormality in the acid-base handling. So let us have a look at the acid-base handling by the kidney. 2 things have to happen in the kidney. One is the bicarbonate has to be reclaimed. The bicarbonate is to be reabsorbed, so that the total bicarbonate that is lost in urine is only 0, because 100% of bicarbonate gets reclaimed. PCT 85% and DCT is 15%. And the second function of the kidney tubule is to deal with the H ions. And so the H ion is to be secreted from the body. The H ion is produced daily. We have daily acid production by assimilating the food that we eat. and that will produce around 2 to 4 milliequivalent per kg body weight of HION daily. And this HION will be, one is neutralization by bicarb, but that is not enough. So we have to have the excretion of titratable acidity, which is happening with ammonium as well as HPO4, H2PO4, sulfates, phosphates, and all these which are neutralizing the HION, and this will be getting excreted in urine as titratable acidity. And so since ammonium formation is important, ammonia genesis that is happening in the kidney is also important. So any step that is abnormal or any of these metabolism of this ammonia genesis or the bicarbonate reabsorption that is getting affected can result in an alkaline urine with a metabolic acidosis, and that is what we call as renal tubular acidosis. Here the anion gap is normal because for every bicarbonate moiety that is going down, the chloride is getting reabsorbed, so that the chloride, the anion gap calculation, the positive side remains actually equal, because for every 1 millimole of bicarb lost or utilized, 1 millimole of chloride is retained. And in these children, actually, they are not in severe renal failure. The GFR will be above 30 ml per minute. And this constellation of findings will make us realize that renal tubular acidification is defective or bicarbonate excretion is defective. And we call it by the name renal tubular acidosis, and which can be a proximal RTA, which is the problem when the proximal tubules are not functioning well and this 85% bicarbonate reclamation is not happening. Or it can be distal RTA when actually the distal HION secretion is not happening because of some problem that is happening with the ammonia genesis or the titratable acidity and problems like that. And the third thing is type 4 RTA, where the aldosterone is either not there, hypoaldosteronism, or even if aldo is there, aldo is not able to act. And this happens usually following obstructive nephropathy. So the distal renal tubular acidosis, children will be presenting with failure to thrive, with normal anion gap metabolic acidosis, hypokalemia, their urine pH will be more than 5.5. The urine anion gap will be positive. That is because the ammonium excretion is not happening, the urine anion gap will be positive. And they do have, because of this severe metabolic acidosis that is there, as the daily acid cannot be excreted out of the body, they will have to the body will be taking a lot of this calcium carbonate from the bone. The leaching of bone will lead to calcium coming out of the bone, producing hypercalcemia, hypercalciuria. And at the same time, because of acidosis, citrate production is also defective. So there is hypocitraturia. These two will contribute to the nephrocalcinosis. And because the bone is getting leached, there will be bent bones and deformed bones. And we will make a diagnosis of rickets in such children, which is a hypocalcemic rickets. And you can see this X-ray, which is showing classical medullary nephrocalcinosis. And this problem can be usually what we come across is congenital, which can be due to a mutation that is happening in the this distal tubule, the acidification segment, which is affected, this H+ pump mutation or anion exchanger mutation, or it can be an immune mediated problem as in lupus or Sjogren syndrome, or it can be secondary to some disorders, like if there is nephrocalcinosis due to any etiology, slowly they can have a distal acidification defect as well. So what we should be doing for kids like that, who will be presenting usually in infants, we have to correct the dehydration, we have to correct hypokalemia before acidosis by giving then after the initial acidosis correction is given, because they will usually be presenting in a decompensated state with very severe metabolic acidosis. So we have to give a lot of alkali to correct the bicarbonate, to correct the acidosis, sometimes ventilate, sometimes do a peritoneal dialysis. But after stabilization, the alkali supplement daily dose will be around 2 to 3 milliequivalent per kg body weight per day, which is the same as the amount that is needed to neutralize the daily acid production. And we have to just correct the acidosis with alkali supplements and correct hypokalemia. And this will correct the hypercalciuria. And these people, whoever may be having severe rickets, but they don't require any vitamin D analog for correcting the rickets. And remember one more thing, that vitamin D analogs may cause more hypercalciuria and nephrocalcinosis in these people. So what we have to, after stabilization and the treatment is initiated, don't lose the follow-up. You have to maintain them under your regular follow-up, monitoring the growth, the bicarbonate which is to be maintained above 22 in a child and above 20 in an infant, and urine calcium creatinine ratio should be maintained in the normal range so that further nephrocalcinosis will not occur. And children with distal RTA need close monitoring so that the growth is completed. And also you have to understand that they are at risk of chronic kidney disease progression if the hypokalemia remains uncorrected and the hypercalciuria goes on with the years, producing the medullary nephrocalcinosis that also will produce a chronic tubulointerstitial nephritis. And so untreated distal RTA, they can go for CKD and ESRD, but at the same time, distal renal tubular acidosis is one of the tubular disorders which is eminently treatable, and we can have a very good outcome if you are managing them properly. So let us further see some more kids who are having bony deformities and not growing well. This 8-year-old female presented to us with very much bent bones and short stature. She had already received multiple doses of vitamin D and calcium from the age of 3 years with not much benefit. And so this child is having growth failure and she is also having rickets. And so let us look at her labs. Her calcium was remaining normal, possibly or even on the more than 9, maybe because of the calcium and vitamin D supplements. But look at her phosphorus, which was remaining low, and the alkaline phosphatase, which was elevated, which is indicating that this child is having an active rickets. And creatinine is in the normal range. The GFR is normal. Her bicarbs is only 18 and her pH is 7.32 and her chloride is high. So we can say that this child is actually having a normal anion gap metabolic acidosis because the anion gap is 11. And her then, because she is having a very low phosphate, a fractional excretion of phosphorus was checked, and that was 17.5%. And so because there is metabolic acidosis and she is also having a phosphate excretion in urine, phosphaturia, the amino aciduria and glycosuria was also checked, and that also was found to be positive, indicating that there is a generalized renal tubular, this proximal tubular dysfunction that is there. So the constellation of problems here is growth failure, rickets, normal anion gap metabolic acidosis with a low serum phosphate, phosphaturia, and hypokalemia. So this is generalized proximal tubular dysfunction, and so this is actually the Fanconi syndrome. So here there is an impaired proximal reabsorption of filtered bicarbonate, and delivery of large amount of bicarbonate is going to the distal tubule, but the distal tubule can reabsorb only 15% of what is coming, and so this will result in bicarbonaturia. And once the bicarbonate is getting lost, sodium is also getting lost, and so this will lead to calciuresis as well. And so the distal acidification intact is something that we have to find out by giving them as acid load test, or sometimes by inducing acidosis. We can see that since the distal acidification is defective, these people will be able to bring their urine pH below 5.5 as we are able to induce metabolic acidosis. When the blood pH is below 7.2 and bicarbonate is below 18, the bicarbonaturia will disappear. And so this also can be congenital or acquired. Congenital problems, always remember, whenever you see a proximal RTA, always you have to look for other proximal tubular functions as well, and then evaluate these children for evidence of cystinosis, tyrosinemia, galactosemia, Wilson's disease, Lowy syndrome and all, because such diseases, especially cystinosis, is having a long-term progression and they will reach ESRD, and not only the kidney is affected, other organ systems can also be affected. And looking at the eye will help you, will give you a clue to the presence of whether cystine crystals are there in the cornea. And these children may present with very severe growth failure, and they will be having reluctance to look at light because of the photophobia that is there. So a small failure to thrive child with short stature and bent bones who is having difficulty in looking at the light, you have to think of cystinosis. And so some drugs which can produce proximal tubular dysfunction also needs to be taken, means history should be taken. One of them is acetazolamide, which is the carbonic anhydrase inhibitor, then anti-epileptic drug valparin sodium. Such things we may not actually think of and take a good history sometimes. And so the treatment is again correcting acidosis and hypokalemia. And one thing that we have to understand is Even though the acidosis is less severe in proximal RTA, the bicarbonate requirement is high at 10 to 15 milliequivalent per kg body weight per day, because you are actually flooding the proximal tubule with bicarbonate so that the percentage reabsorption will be able to correct the metabolic acidosis. So this baby, 6 years, presented with deformities of the limbs and growth failure, severe short stature. There was bilateral genu valgum. The X-ray was showing cupping and fraying, and this is the case that I was just telling you. This child was having generalized proximal tubular dysfunction, and the slit lamp examination showed that her cornea is studded with crystals, and this was the slit lamp examination. Pathognomonic, refractile, intracellular crystals were there, and this child was actually having cystinosis. And cystinosis, actually, these children, if they are not picked up in time, they can develop renal failure by adolescence. Even if you pick them up in India, we are not able to give them proper treatment because the drug is not available in India. And cystinosis not only damages the kidney, but it damages the endocrine organ systems, producing hypothyroidism. There is a delayed puberty. There is exocrine pancreatic deficiency, diabetes, hepatosplenomegaly. They can have myopathy. They can have CNS involvement, calcifications, atrophy, pseudotumor cerebri. Photophobia we have already discussed. And so the supportive therapy is what we can do for these kids as well, with correction of acidosis, oral phosphate supplements, carnitine, growth hormone, and thyroxine. Cysteamine tablets, if it is available, that is the specific therapy. We have cysteamine drops available to us that is going to be actually tackling the eye issues to some extent. But if we are not having such treatment facilities, because cysteamine tablet is expensive and it has to be imported from the Western countries, we usually end up not giving the tablets, and these kids will progress and they will end up getting a kidney. And even after kidney transplantation, they need to be kept under follow-up because of the progressive other organ dysfunctions that are going to be there. Type 4 RTA is also called hyperkalemic RTA, and basically it is the aldosterone that is not able to act at the distal tubule. And so hypoaldosteronism can be a primary hyperaldosteronism or hypoaldosteronism, or it can be associated with CAH. And other acquired problems are pyelonephritis and obstructive nephropathy. We come across such boys too often. When some child is having posterior urethral valve and chronic kidney disease, they will be having, even when the GFR is reasonably good, they will be presenting with hyperkalemia requiring management, and also metabolic acidosis will be there, and we will be making a diagnosis of type 4 RTA. Mineralocorticoid supplement and alkali supplement is the treatment for supportive management, but the correction of the underlying disorder is important, the relieving the obstruction and treating the infection. But at the same time, even with that, these children will require long duration alkali supplement and mineralocorticoid. So this is the tubular disorder producing. These are the three major forms. So whenever you see a hyperchloremic metabolic acidosis, you have to look at the urine net charge. And if it is positive, the urine charge is positive, you will be making a diagnosis of renal tubular acidosis. This is urine net charge is urine anion gap. Urine anion gap is positive in renal tubular acidosis. It will be negative in distal in diarrhea. And once you have the urine anion gap positive, then you have to look at the urine pH. And urine pH cannot be brought below 5.5 in distal RTA, whereas in proximal RTA, with more and more acidosis happening, you can actually bring it below 5.5 as the distal acidification function is normal in proximal RTA. Fractional excretion of bicarbonate is actually normal in distal RTA, whereas it is very high in proximal RTA. So this is a comparative table which is again telling you the recapitulating the findings. Fractional bicarb excretion, which is more in proximal RTA, the urine pH which can be brought below 5.5, nephrocalcinosis is usually absent, and then these are the treatment solutions that we used to give previously, but now Scholl solution and polycitra is getting replaced by oral sodium bicarbonate tablets. So then next, another problem, you have to think of a renal tubulopathy when you are having a child coming to you with severely bent bones and which is not and diagnosed as rickets outside and getting lot of calcium and vitamin D supplements, thinking of it as a nutritional rickets, but not getting corrected. So when such severe deformed bones and short stature is coming to you with fractures and resistant rickets, like this, you have to think of an underlying tubulopathy, which is to be assessed and evaluated. This was a 4-year-old girl who came to us in 2009 with short stature. She was 4 years. Her father was also very short, and he was also having the similar bony deformity, and her x-rays were showing evidence of florid rickets. She was having a phosphate that was low, her alkaline phosphatase was high, and tubular reabsorption of phosphate was 78%. And this was the problem with this child. She was not having acidosis. So in the absence of metabolic acidosis, hypophosphatemia, rickets, and phosphate wasting is there. So we have to think of the protein that is involved in renal phosphate absorption that is defective. That is sodium phosphate cotransporter. And so this is the familial hypophosphatemic rickets. Or that is a misnomed name is vitamin D resistant rickets. People used to give a lot of vitamin D for these people. Actually, this is actually not vitamin D resistant rickets, because the vitamin D is actually normal. Vitamin D receptors are normal. The problem is phosphate urea. And so we have to give them phosphate. And because the vitamin D activation is happening in the proximal tubule, and this is a proximal tubular dysfunction, we have to give active vitamin D also to these people along with phosphate supplements. And these are the doses that we will be starting. Remember one thing, phosphate supplements sometimes will have to be escalated to maintain the phosphate above 3, and that is our aim. And by giving lot of phosphate, actually the child can develop diarrhea, and so you have to titrate and give the phosphate in 5 divided doses at least, so that the levels are maintained uniformly, as well as the diarrheal episodes are less. So now we have to move more distally. As I have told you, whatever we know is very limited, and there may be more and more protein abnormalities that have to be detected, and more diseases which we are ill-informed may come out as tubulopathy subsequently. So let us look at what is happening, some problems that are happening in the more distally. So this little baby again came to us at 1 month of life with failure to thrive. And this was a female baby. She was born as a preterm with 1.7 kg to a second gravida mother. The consanguinity was non-consanguineous. There was history of polyhydramnios. At 1 month, the baby weight was less than the birth weight, and there was history of passing a lot of urine. Baby was dehydrated, lethargic, and in shock. System examination was non-contributory, and external genitalia was normal. And looking at the urine, it was more than 8 ml per kg per hour with a specific gravity of 1.010. She was having hyponatremia, severe hypokalemia, hypochloremia, and her blood gas was showing metabolic alkalosis. Bicarbonate was 38. And you can see that she was wasting potassium, she was wasting sodium, she was wasting chloride in urine. And the urine to spot calcium creatinine ratio was 1.9. She was also having pre-renal azotemia, and her magnesium was borderline. Her abdomen ultrasound was showing medullary nephrocalcinosis. And because she was having a blood pressure that was on the lower side, dehydration, and she was almost in shock and all, we thought of doing the renin activity and aldo, and those were found to be high. And so this baby was having metabolic alkalosis and hypokalemia. So what is the approach to metabolic alkalosis and hypokalemia in any patient? We have to assess the urine chloride to see whether the chloride is getting conserved by the kidney or chloride is getting wasted by the kidney. So when the chloride is below 10, it is extrarenal loss. The kidney is not at fault. Kidney is working well. But if the urine chloride is above 10, that means even with very severe hypochloremia, this kidney is not able to conserve the chloride. We have to check the blood pressure. Blood pressure is normal or low. We will be making a diagnosis of Bartter-Gittelman or diuretic abuse depending on the clinical presentation. And if it is high, blood pressure is high, we will be checking the aldo, and aldo is high, then you know that you are dealing with primary hyperaldosteronism, and that is causing the high blood pressure and hypokalemia, metabolic alkalosis. Whereas the blood pressure is on the higher side, but aldo is normal or low, It could be some terminal receptor problem as epithelial sodium channel is defective as in Liddle syndrome, or a CAH, or an apparent mineralocorticoid excess, or a glucocorticoid remediable aldosteronism. So those are actually not of our interest in this discussion. So further evolution of events that happened with our baby who was having hypokalemic metabolic alkalosis with hypovolemia, salt wasting as nephrocalcinosis. We did a genetic study, and that child was having a CLC and KB mutation that was suggestive of a classic Bartter syndrome, that is Bartter syndrome type 3. And so further course of events, the baby was dehydration was corrected. Indomethacin was started at a dose of 1 milligram per kilogram per day. You can actually escalate to 3 milligram slowly, monitoring the RFT and potassium. And spironolactone was also added, and oral potassium supplements were also added. Polyuria and thirst decreased. Dehydration got corrected. Baby started tolerating feeds and oral medicines. Her weight started improving, and serum sodium was 130 and potassium was 3.3. And then this child was under continued regular follow-up, because to optimize the outcome, we have to monitor these babies, because the dehydration and hypokalemia can further damage the kidney. The indomethacin that we are doing needs to be titrated, and that adjusting the dose is important for maintaining the baby in the normal kidney function. Then, so Bartter syndrome is actually an autosomal recessive salt wasting tubulopathy, which is because of the mutation in the diuretic sensitive sodium channels. This is the NKCC2 channel, which is important in the transport, and this is the potassium channel, which is important in maintaining the potassium levels in the tubular fluid. And then this is the CLC-Ka and Kb, the chloride channels. And this was the problem that our baby was having. It was a CLC-Kb mutation. And so these children usually present in infancy, and polyhydramnios, prematurity, polyuria, dehydration, failure to thrive, and nephrocalcinosis will be commonly seen. And the diagnostic metabolic abnormalities that will be there is hypokalemic metabolic alkalosis with hypokalemia and salt wasting. And the treatment is salt and volume replacement, potassium supplement, spironolactone, indomethacin, and even AC inhibitors may sometimes be useful. And a very close mimicker of the problem, but that occurs in a school-going child who will be having salt craving, polyuria, constipation, and they usually will be presenting with muscular weakness and cramps, especially going for trekking or following this intense physical exercises. They develop fatigue, carpopedal spasms, tetany, muscle weakness, and all. And growth retardation is not very common in this particular syndrome, and that is Gitelman syndrome. And so the treatment is actually, there is no drug that is to be given for these people. They need only magnesium and potassium supplements to maintain magnesium and potassium in the normal levels. So how to differentiate between Bartter and Gitelman? Both will be having polyhydramnios. Failure to thrive is there more in Bartter, but not much in Gitelman. The age of presentation is what is more important. Polyhydramnios in Bartter, failure to thrive in Bartter, presentation in infancy and early childhood is Bartter. Tetany is not there in Bartter syndrome, but it is there in Gitelman syndrome. Muscle weakness and tetany and seizures, and you may be thinking that it is the hypocalcemia that is, but giving calcium is not going to correct the abnormality. Magnesium has to be supplemented, and so hypomagnesemia, metabolic alkalosis, and hypokalemia in a school-going boy or an adolescent or a young adult, we have to think of Gitelman syndrome. They don't have medullary nephrocalcinosis because their urine calcium excretion is actually on the lower side. Then, so we have dealt with acid and base, and the water is remaining. So there are some abnormalities associated with water handling, and the renal collecting tubule water handling. We all know the aquaporin channels and the V2 receptors and all. And if there is a tubular unresponsiveness to the antidiuretic hormone, the disease that is diabetes insipidus. And this can be due to congenital mutations in the V2 receptor, which is the most common one, that is X-linked, seen in boys, or it can be an autosomal recessive or dominant as due to abnormality of the aquaporin 2 channel. The aquaporin 2 channels are actually remaining in the cytosol, and they get inserted to the wall of the tubule only if the V2 receptors are activated. And this can be congenital or acquired. Acquired can again occur, you see, the chronic kidney diseases per se, obstructive nephropathy, sickle cell disease, and even nephrocalcinosis can sometimes cause a nephrogenic DI. So this male baby presented at 4 months with polyuria and increased thirst. He was craving for water. He was irritable. He was having failure to thrive, and he was having seizures and mental retardation and hypernatremic dehydration. So this baby who is polyuric, we have to look at the pH and bicarb as we usually do, and that will be normal in these babies. And we also have to rule out, you have to look at the urea and creat and the urine specific gravity. In chronic kidney disease, some salt wasting nephropathy, isostenuria, they can also be polyuric. But in the diabetes insipidus, actually, none of these problems will be there. The blood glucose also will be normal. Diabetes mellitus is another DD that we have to consider. And in this scenario of normal GFR, no acidosis, normal blood glucose and urine glucose, you will be looking at the urine osmolality and simultaneous plasma osmolality. And water deprivation is contraindicated in infants, and water deprivation usually is not required in children if they have this urine specific, the plasma osmolality, which is almost very high, and here this serum sodium that is more than 160 and all, a water deprivation is not required in such children. You have to just have a look at the urine osmolality and simultaneous plasma osmolality. And if at all, if there is a doubt and you're doing water deprivation, you have to give this water deprivation under in the hospital under medical care, so that the percentage of weight loss is to be tackled. You should not go above 3% of weight loss, 2 to 3% weight loss. And you should also be looking at the serum sodium, blood pressure, and child should be under your close monitoring. So this is the rising urine osmolality. If it is happening with vasopressin more than 50%, then you know it is central DI, which is actually more easy to treat. Whereas nephrogenic DI is a difficult disease to treat. We have to reduce the solute and the salt in the diet. You can use thiazide diuretics. Indomethacin actually will be reducing the glomerular filtration rate and thus reducing the filtrate volume and the urine volume. Amiloride is another molecule that we can use. So then final one, a 16-year-old girl with recurrent episodes of fatigue and headache presented to us. 2 siblings also had the same complaint, and physical examination revealed severe hypertension, 180 by 120. Hemogram was normal. The blood pH was 7.48 and bicarbs 30. The potassium was on the lower side. Urinary potassium wasting was there. GFR was normal. Sonologically, kidneys were normal. And the child was actually having, it was difficult to control blood pressure. So we did the renin-aldosterone. The renin was suppressed and aldo was undetectable. And so this child was actually having an autosomal dominant problem, that is a low renin hypertension. It was a Liddle syndrome, which is an activating mutation in epithelial sodium channel. The sodium channel is now activated, that sodium reabsorption is happening at a very high rate, and potassium is wasted, and there is metabolic alkalosis. The treatment in this condition is giving this ENaC channel blockers, that is amiloride, triamterene, and a low salt diet. And so going to the last problem that we have to deal with is a renal stone disease. And this renal stone disease is also a tubulopathy where the calcium oxalate and all handling may be defective. This crystalluria, graveluria, and renal stone is a problem in various disorders, which can be cystinuria, dense disease. And so we have to actually, when you see urolithiasis or nephrolithiasis in small children, a genetic evaluation is mandatory to detect disorders like this. So the common tubular disorders that we may come across are involving the proximal tubule. It can be aminoaciduria, which can be generalized or isolated. I have not dealt with renal glycosuria. Renal glycosuria is actually a benign issue, so we sometimes come across them thinking that my child is having diabetes because she is having glucose in urine, and so you will be actually telling them not to worry and keeping them under follow-up. So the renal transport defects affecting the proximal tubule can be producing these issues. In the ascending limb of loop of Henle, we have the Bartter syndrome producing a salt wasting nephropathy. Then distal tubule, distal RTA, and Demand syndrome. In the collecting duct, we have got the Aldo-mediated defects, Liddle syndrome, and nephrogenic diabetes insipidus. So to recapitulate, renal tubule is a nature's wonder. and little babies failing to thrive. That is the most common issue that a pediatrician may come across, which can be a salt wasting tubulopathy associated with metabolic acidosis and hypokalemia or metabolic alkalosis and hypokalemia. Bent bones and stones are a problem, and losing lot of water and water alone getting lost is another problem. And blood pressure too high is also, we have to think of the tubule as the culprit. And so we have to suspect, we have to evaluate, we have to diagnose, initiate the treatment and keep them under follow-up. Let us try to keep these babies, giving them a bright new world and a good growth and good hydration status. Thank you.
Thank you so much, madam, for covering so much in such a short time. You have almost finished the whole gamut of tubular disorders. So we have come to the fag end of the program. To deliver the last talk, which is on acute kidney injury, we have Dr. Anil Matthew, who will be speaking on AKI in PICU and sepsis. Dr. Anil Matthew is a clinical professor in nephrology at AIIMS Kochi. He did his MBBS from Kottayam, MD from KMC Mangalore, DNB Nephro from AIIMS Kochi. He has 15 publications in national and international publications. His areas of interest are renal pathology and pediatric kidney transplant. Over to you, sir.
Is my slide visible?
Yes, sir, it is.
Good afternoon to all. As the last session, I would like to present a bird's eye view of AKI in PICU and sepsis. I'll try to be as simple as possible and will try to deliver 2 or 3 take-home messages. Even at the time of Hippocrates, abrupt reduction in kidney function leading on to edema, which was associated with a febrile illness, was known. And for centuries, it was known in different names. For decades, for the entity, a singular term of acute renal failure was used. Until about 2002, there was no significant systematic terminology or adequate staging for the entity. And in 2004, the Acute Dialysis Quality Initiative proposed the rifle criteria, risk injury failure loss, and end-stage criteria for adults. And it was modified for children in 2007, along with the acute kidney injury network classification. And in 2012, the KDIGO proposed the present definition as well as the classification what we use. So acute kidney injury can be defined as an increase in serum creatinine equal to or more than 3 mg/%, or increase in serum creatinine equal to or more than 1 times, which is known or presumed to have occurred within the past 7 days, or urine output less than 0.5 ml/kg/hour for 6 hours. The stages of AKI can be relatively easily understood as 3 stages. There are serum creatinine criteria, there are urine output criteria. Serum creatinine criteria, stage 1 is 1.5 to 1.9 times the baseline, or more than 0.3 absolute increase. Stage 2 is increased by 2 to 2.9 times the baseline, and stage 3 is increased more than 3 times the baseline, or an increase, absolute increase above 4 mg/%, or the initiation of kidney replacement therapy. As per urine output criteria, the stage 1 is less than 0.5 ml/kg/hour for 6 hours, and stage 2 is 0.5 ml/kg/hour for 12 hours. Stage 3 is less than 0.3 ml/kg/hour for 24 hours, or anuria for more than 12 hours. In hospitalized children, the reported incidence ranges from up to 5% or less than that, but more common in critically ill children. That is, up to 30 to 50% of them are reported to have acute kidney injury. According to a paper published by Goldstein, it is the commonest medical complication in critically ill pediatric patients. And a Thailand study showed that acute kidney injury rates increased 20-fold in a time span of 22 years. Probably it is because of the increased awareness of acute kidney injury and increased number of children undergoing procedures as well as who are getting nephrotoxic medications. Sepsis is a severe and dysregulated inflammatory response to infections characterized by an end organ dysfunction distant from the primary site of infection. And it is one of the leading causes of acute kidney injury. Accounts for 25 to 50% of all acute kidney in children and 33 to 50% that in adults. Sepsis-associated acute kidney injury is associated with increased comorbidity, high mortality, and greater resource utilization like longer hospitalization, intensive care, ventilatory support, dialysis, etc. And not only short-term problems, it can lead on to long-term sequelae like chronic renal failure and ESRD. This is one of the largest studies regarding the epidemiology of sepsis-induced acute kidney injuries, which was done in 128 PICUs across 26 countries, the Sprout study, which came in 2000, which was published in 2015. Out of that, 102, that is 21%, had severe acute kidney injury. Hospital mortality was 25%, and severe and 17% of the survivors had new or moderate or worse disability at hospital discharge. It showed severe acute kidney injury as an independent risk factor for death or new morbidity or disability. Our experience at our hospital also shows a significant number of acute kidney injuries are associated with sepsis. In critically ill patients, what produces this acute kidney injury? It is multifactorial. It can be because of the kidney hypoperfusion, which results from many causes. It can be a direct kidney tissue injury because of nephrotoxic medications or a prolonged or impaired kidney perfusion. Less commonly, acute kidney injury in this setting can be because of the primary kidney diseases like hemolytic uremic syndrome or sepsis-associated GN. The pathogenic pathways which are involved in the mechanisms of sepsis can have significant impact on the pathophysiology of sepsis-induced acute kidney injury. The microbial insult affects the pro-inflammatory state as well as the anti-inflammatory state. In the pro-inflammatory state, it produces complement and coagulation pathway activation, protease activation, free radical formation. It causes release of many cytokines and significant cellular involvement also. On the anti-inflammatory side, it produces increased IL-10, poor phagocytosis and chemotaxis, overall causing significantly deranged immune function. All this leads to, the imbalance between these two leads to a cascade of events like mitochondrial dysfunction, apoptosis, necrosis, endothelial dysfunction, metabolic acidosis, capillary leakage, thrombosis, oliguria, impaired vascular tone, resulting in multi-organ failure, acute kidney injury, and death. So the point I want to stress is the pathophysiology of sepsis and AKI. They share many common pathways and synergistically contribute to the quick deterioration of these patients. Again, another major study which was published within the last 5 years, that is in 2017, the AWARE study, which involved 32 pediatric ICUs. The AK incidence was 26.9% during the first 7 days of ICU admission. 11.6% of critically ill children had severe AK, that is stage 2 or 3, and severe AK had shown as a statistically independent risk factor for mortality. It was also associated with the secondary outcomes like a need for the kidney replacement therapy, increased mechanical ventilation, and lengthy ICU stay. In the post hoc analysis of this study data, AWARE data highlighted the importance of utilizing both the urine output and the serum creatinine criteria to identify AKI. Isolated use of creatinine criteria alone would have missed nearly 1/3 of the acute kidney injury cases. And moreover, the mortality rate was much higher when both these criteria were met to define acute kidney injury. But in the past, majority of the childhood acute kidney injury studies did not utilize the urinary criteria. Even now, many times we have an inhibition of inserting a Foley's catheter in a suspected AKI child. And documentation of urine output, because that being a dynamic parameter, there are difficulties, practical difficulties in getting a good documentation, especially if it is recorded electronically. Here, the main point to note is oliguria is a crucial component to recognize acute kidney injury, and drop in urine output should prompt evaluation of the kidney function and more careful management of fluids and nephrotoxic agents. Now we will see the AKI happening in few cohorts in the PICU, specific cohorts. Children undergoing cardiac surgery. It's a non-complication in children undergoing cardiac surgery, especially when they undergo cardiopulmonary bypass. Cardiopulmonary bypass leads on to the pathophysiology of acute kidney injury in many ways. And the risk factors, one of our residents studied the risk factors in this cohort in children, and she found that low weight, complexity of the cardiac effect, higher the creatinine level, decreased pre-op cardiac output, high inotropic requirements, CPB time, these were found to be the risk factors for these children. And AK post-cardiac surgery is associated with longer hospital stay, need for mechanical ventilation, and it increases the risk of mortality as expected. In neonates, the AKI, the risk factors are prematurity, perinatal asphyxia, PDA, low birth weight. I'm not going into the exhaustive list, but sepsis is one of the important factors in neonates also. And more than 50% of children who develop necrotizing enterocolitis, they have significant AKI. But here in neonates, acute kidney injury definitions and diagnosis is limited by many factors, including the poor performance of serum creatinine and its fluctuating levels in the first week of life. And AWAKEN study, the assessment of worldwide acute kidney injury epidemiology study in neonates, showed an overall incidence of about 30%. And when the gestational age is less than 29 weeks, the incidence is nearing 50%. And it is also associated with increased mortality and longer hospital stay. In the present scenario, this cohort is also important, acute kidney injury in children with COVID. The risk is more significantly greater with MISC and when there is inotropic requirement. We have to understand the difference in pathogenesis between acute kidney injuries in acute SARS-CoV-2 infection and MISC. In acute infection, it is the combination of both renal hypoperfusion and direct renal parenchymal damage. Whereas in MISC, it is the pre-renal component which is more important, which is resulting from cardiac dysfunction and capillary leakage because of the hyperinflammatory state. In children receiving ECMO, FITMO study showed 60% increase of incidence, 60% incidence of acute kidney injury. And this study showed the volume overload as a modifier risk factor in development of acute kidney injury. So in such a situation, how to improve the outcome? A multifaceted, timely, rational, and systematic approach is required in the management of these patients. First step is to identify which child is going to develop acute kidney injury, which child is at significant risk of developing acute kidney injury. And we should start the treatment of sepsis at the earliest. Early initiation of antibiotics reduce the mortality in different studies. How can we identify these children early? There are various ways. There are genome-wide association studies have shown it has got the potential to identify these patients at high risk of acute kidney injury. Then there are various biomarkers which are being studied. At least one or two of them are being clinically used. Renal angina index is showing some promising results in predicting risk stratification. Renal angina index proposed mainly by Goldstein in children. Now, studies are being done in adult cohorts also and showing fairly excellent results in predicting the risk of AKI. Here, there are risk levels and injury levels which are multiplied, and renal angina index is calculated. In risk levels, in pediatric sepsis, ICU admission, diabetes or stem cell transplantation, ventilation and inotrope. And in the injury level, there is a decrease in estimated creatinine clearance or percentage fluid overload. These are the parameters calculated, and the renal angina index is calculated based on this. Most of us are aware of the Surviving Sepsis campaign. In the first 1 hour, hour one surviving campaign, a few guidelines are there which helps in reducing the sepsis-induced acute kidney injury. Measure the lactate level and remeasure if the initial lactate level is more than 2. Obtain blood cultures before starting antibiotics and start broad spectrum antibiotics at the earliest. Begin rapid administration of 30 ml per kg steroid for hypotension or if the lactate level is more than 4. And apply vasopressors if patient is hypotensive during or after fluid resuscitation to maintain an MAP of more than 65. What is the impact of volume overload in PICU patients? And these critically ill patients are vulnerable to volume overload in many ways. The systemic inflammation, the capillary leak, and the arbitrary use of intravenous fluids to manage hypertension, all this contributes to the volume overload. And the percentage volume overload can be calculated by total fluid in minus total fluid out by admission weight in kilogram into 100. And a 2018 meta-analysis of a large number of studies showed that the fluid overload carries a greater risk of mortality and the need for prolonged ventilator utilization. And another study which came in 2017 showed conservative fluid strategy leads on to an increased number of ventilator-free days and decreased length of ICU stay compared to liberal fluid strategy or standard care without observing a difference in mortality. So it should be, these management should be supported by regular assessment of creatinine and meticulous monitoring of the urine output and weight, limitation of nephrotoxins, and the medications have to be modified as per the estimated GFR, avoiding contrast, and following up the AKI care bundles. When do we initiate kidney replacement therapy in a child with AKI? When more than 15% of the percent volume overload, cumulative volume overload is there. When there is persistent hyperkalemia or metabolic acidosis refractory to medical management, or when there are complications due to uremia like uremic pericarditis or bleeding, or when they remain oliguric despite diuretic therapy with the need for large amount of IV fluids or escalating ventilator requirements. What are the kidney replacement therapy modalities which are available? We can use peritoneal dialysis, intermittent hemodialysis, or continuous kidney replacement therapies. But definite data is insufficient to recommend one modality over other. So how do we select the modality? It is based on patient factors like size, underlying illness, ability to obtain a vascular access, and the local expertise and experience with the available resources. When do we initiate kidney replacement therapy in the case of acute kidney injury? Do we have to start early, or can we wait and then initiate? It's a debatable question, and some studies have some meta-analysis have shown that there's no difference between early versus late. But often what practically we see is when we wait, the patient becomes hemodynamically unstable because of the disease progression, and we won't get time to initiate the RRT. And initiating RRT in a critically ill child requires a collaboration. It's a teamwork. So other subspecialties, other consultants involved, everybody has to be coordinated. So we have to start early. We have to start early discussion planning to facilitate the process, which improves the survival. I'm not going into the details of acute care, AKI care bundles. And a few targeted therapies are in the pipeline, and some of them are being in clinical use. Early inflammation to attenuate that, endocannabinoids may be useful. And what we use, especially more in adults in such settings, are cytosorb, the selective cytophoretic therapy, and polymyxin hemoperfusion can be also used. I know this is a very congested table. None of you are going to read much information from this table, but I put this because there's a significant number of emerging therapeutic targets being tested in animal models and clinical trials. So maybe in next 1 or 2 decades, we will get more useful treatment modalities to our sepsis treatment armamentarium. What is the prognosis of these children who develop a acute kidney injury while they are in PICU? The overall survival rate is between 50 to 75% in children who receive kidney replacement therapy. What are the risk factors for mortality? The underlying disease, the high presence of hypotension, if there is significant fluid overload at the starting of kidney replacement therapy, requirement of inotropic therapy during kidney replacement therapy, and in infants less than 1 year of age. But not only the immediate results, the long-term results are also not very good. In a cohort of stem cell transplant recipients, patients who developed AKI and required renal replacement therapy, after 1 year, in 50% of the survived patients, they had significant chronic kidney disease. So all those who develop acute kidney injury in ICU, they should be promptly followed up. Long-term surveillance is required for the development of CKD. I've put this paper just to highlight the importance of identifying the clinical phenotype of acute kidney injury. Don't get confused by the term clinical phenotype. It just means that we are taking into account the duration as well as the severity of AKI. That means when we consider AKI, it can be a transient AKI or it can be a persistent AKI. It can be when we consider severity, it can be a mild AKI or a severe AKI. So the prognosis will depend on this type of clinical feature, especially if it is a persistent severe AKI. The prognosis will be definitely bad compared to a mild transient AKI. So a singular term, what we were using in the past, like acute renal failure, and the present narrowing down the definition to significant, the particular phenotype of acute kidney injury. That is the benefit and in terms of early identification and prognostication. So to summarize, AKI is very common in pediatric ICUs, especially in septic children. It is associated with significant adverse outcomes. Yes, it is possible to identify the risk factors. We can take different steps to prevent the AKI. Prevention is better than cure, is very important in this case. We have seen why it is more important to recognize oligolia early, and we have also seen why timely intervention with special attention to volume status is important in saving these kids. And last but not the least, follow-up of these kids for development of CKD is all the more important. Thank you for your patient listening.
Thank you very much, sir, for that very practice-oriented talk. With that, we come to the end of today's program. I would like to thank all the faculty who presented, all the delegates who attended. We had a very decent attendance, and most of you stayed back till the last. Thank you, everyone. Thank you, IAP Kochi, for organizing. So hope we meet in person for the next Nephro conference in 2022. Thank you all.
Thank you.
By this, we end the day's program.
Thank you all.